Yes, we are live.
Good evening, folks. A very warm welcome to all of you again to our new sequence of VRSI's national webinars. This one on the August occasion of our National Independence Day. And join us today is one of VRSI's closest friends and great teachers, our VRSI legend speaker for the day, Dr. Steve Charles from USA. Thank you, Dr. Charles, for being with us today. He actually needs no introduction, but by way of a few words, he is the founder and head of the famed Charles Retina Institute. He's one of the widely recognized names in vitreoretinal surgery, having authored leading textbooks in over 200 publications. Prolific innovator, he's been named by Ocular Surgery News as one of the top 10 innovators in the past 25 years and has been inducted in the University of Miami Medicine's Hall of Fame. A mechanical and electrical engineer, he has incredibly over 150 issued or pending patents, and he has received several honors like the Kelman Innovation Lecture, the Wacker Medal, the Charles Gonin Award, the American Academy Laureate Honoree, and the Founders Medal at the ASRS. He's had a major hand in developing the Alcon Accurus and the Constellation system. A multifaceted personality, he also flies the Falcon and Cyberjets. So welcome, Dr. Charles, again. And along with Dr. Charles today, it's my pleasure to introduce our panelists for the day, Dr. Shobhit Chawla, a prolific surgeon and president of our Vitreoretinal Society of India and director of Prakash Netra Kendra, Lucknow, Dr. Cyrus Shroff, a former president, VRSI, and the head of the Shroff Eye Institute in Delhi, Dr. Pramod Bende, the director of the Vitreoretinal Services, one of India's premier institutes, Retina Institute, the Shankar Nethralaya in Chennai, Dr. Muralidhar, the vice president of the Vitreoretinal Society of India, and one of the leaders of the Retina Institute of Karnataka, another famed institution in southern India, in Bangalore. So with these words, it's my pleasure now to request Dr. Shobhit Chawla to say a few words, open the session, and invite Dr. Steve Charles to give his talk. Thank you.
It is needless to say, as Anand pointed out, Dr. Charles has been one of the main innovators and a person who has made surgery practical, safe, and predictable for all of us. And today he's going to speak in continuation with his last talk, which was about 5 months back. Now he'll be speaking on a very interesting topic. And without much delay, I would request Dr. Anand to invite him for his talk on resurgery.
Thank you. Dr. Charles, please take it away. Your talk on resurgery, my approach and surgical strategies.
Well, thank you very much. It's a pleasure to be involved with my many friends in India. I feel like I'm a part of the country. Let me get rid of this other screen so I can see what I'm doing here. And then we'll start. These are the R words: reoperations, retinectomy, and what I call the reattachment sequence. I'm going to speak rapidly. So what do I mean by reattachment sequence? First, we remove the frontal plane vitreous traction. Why do I call it frontal plane? Because there's no core vitreous in PVR. It's the confluence of the anterior and posterior vitreous cortex, as well as anterior loop traction. Some people call that anterior PVR membranes, which is a misnomer. It's just contracted radial vitreous cortex fibers overlying the vitreous space that pull the equator of the retina anteriorly. The second step is the forceps membrane peeling with the ILM forceps. There's no need for PFO or anything at this stage. Spatulas are a bad idea. Scrapers are a bad idea. Use the ILM forceps and peel inside out. Subretinal bands need to be removed only if they change the retinal contour, if the retina is draped over a band. And I don't use the diathermy, nor do I use the cutter to make a gap in the retina. I do it by what I call punch-through retinotomy. I literally push over the highest point of the membrane, and I'll show you this graphically in a moment. Then I begin internal drainage of subretinal fluid. Don't use the term gas fluid exchange. You're not taking gas out and putting fluid in. Call it fluid air exchange, but do that after you initiate internal drainage. So you start draining through a retinal break or a drainage retinotomy, if there's no accessible break. And when the retina stops moving back, you say, okay, it didn't reattach all the way. Therefore, now it's time to add the surface tension component, which is fluid air exchange. So always initiate drainage first in routine detachments, not just in PVR. Then continue this drainage simultaneously with fluid air exchange. And if you see residual vitreous traction, don't take the air out and start over or put PFO in. Simply do vitrectomy under air, which I also call interface vitrectomy. Then as the retina begins to go back, let's say it was bullous and now you're exposing a star fold that's limiting retinal reattachment, peel the star fold under air with the ILM forceps. It works just fine. Similarly, if you discovered a subretinal band at that point that's holding the retina up you didn't recognize before fluid exchange, you can remove it at that point. Then if the retina won't go back, then and only then do you do what I call incremental retinectomy. So you do the retinectomy under air. Don't do the Mockamer technique of relaxing retinotomy, and I'll tell why in a moment. And then once the retina is reattached, confluent laser, not spots, at the edge of the retinectomy and severed large vessels. Don't use diathermy to the full extent of retinectomy. That's too much necrosis. And then finally, air silicone exchange. So this graphically shows the sequence. So you see the arrows starting in the upper left-hand corner and then proceeding across the bottom. First, subretinal fluid, then fax, then vitrectomy under air if needed, then membrane peeling under air if needed, then remove subretinal band under air if needed, and then retinectomy if needed. Anterior loop traction is, again, radial fibers that were in contact with the retinal surface, extending from the posterior edge of the vitreous space anteriorly. Those must be resected. Today's 25 and 27 gauge cutters are just fine for that. There's no need for scissors as I used to use in the 20 gauge era. Mockamer invented relaxing retinotomy simultaneously with me inventing retinectomy. Retinectomy is better. Why? It removes all residual material anterior to the cut. That includes retina, the PVR tissue, vitreous. And if you do the retinectomy method that I recommend, which you see on the right here, that causes less epicellary tissue, less hypotony, less ptysis. I pulled my fellows via email, and on average, I have a hypotony case every 4th or 5th year, and yet it was 22% of the silicone oil study. Why? People do excessive retinopexy for 1, for 2, they do excessive buckling, and for 3, they do the Mockamer method and leave all the tissue anterior to the cut. Bad idea. What's the advantage of retinectomy under air? You do just the right amount. If you try to do it under saline, you're going to have, you may do retinectomy when it's not required. Often I'll think, well, I need retinectomy. Then I'll do internal drainage and fluid air. Turns out I didn't need it. Other times you can do unnecessary or excessive retinectomy. If you do it under PFO, these people that put liquid perfluorocarbon in every PFO PVR case, guaranteed to have it in the subfoveal space. When you got stiff retina, and particularly if there's a posterior break, and you pour in PFO, you're going to make breaks. PFO is essential for inferior detachments, and you leave it in place for 2 weeks. It's essential for giant breaks, as Stanley Chang taught us, but don't use it in PVR. It's massively overused. So again, I don't want to emphasize any point in this. I've already covered it, except the bottom point, and that is, don't do a lensectomy and then leave the capsule to put in an IOL in the sulcus at a later date. Simply do not do it. Why? The capsule sticks to the peripheral vitreous. It sticks to the back of the iris. The iris becomes concave. The pupil's fixed. The interocular pressure is low because of epicellary tissue. A very bad idea. It's very commonly done. Dean Elliott gave a talk at the Vit Buccal Society, said the same thing. Don't leave the capsule. Yet numerous people do it. I see re-op PVR cases from other surgeons all the time that are coming to me for another operation. What are the common themes? Capsule stuck to the iris, pressures 3 millimeters of mercury, and they put a giant buckle around the eye and all the PVR is supposed to the buckle. What about if you've already got silicone in and the retina reattaches? Don't remove it. Operate under oil. Use the 1,000 Cenoscope silicone oil from Alcon, not 5,000. 5,000 has the same emulsification rate, and use the a non-valve cannula that are in these individual packs, and connected to the Med1 BFI infusion cannula, which fits over it. Therefore, you can infuse oil with the VFC to make up the fluid volume as you remove subretinal fluid and do retinectomy. And you can peel ILM, you can peel epimacula membranes without adding any oil. But if you do a retinectomy and subretinal fluid removal, obviously you must top up the oil to make up the fluid volume. Surgery under oil, every technique that we use under fluid works fine under oil. That includes forceps membrane peeling in the diabetic case, scissor segmentation, delamination for glial recurrences, retinectomy, subretinal band removal, and resection, as well as endophotocoagulation. They all work well under oil. And don't use PFO with rigid retina. It ends up in the subretinal space. So this shows you membrane peeling under oil, which again works just fine. And this shows you actually a two-port technique without adding oil much for epimacular membrane under oil. Lastly, why not scleral buckling? There's a funny story that's a bit derogatory toward Robert Mockemer, who got us started with vitrectomy many years ago. I saw a letter about a patient. He said the retina is substantially reattached. It was a letter to the referring doctor. It was completely reattached on the buccal, and all the retina posterior to the buccal is detached. The part posterior to the buccal is the part you see with. So putting a giant buccal in and looking in there and saying, oh, it looks great. And then they get PVR posterior to the buccal and you got to do a retinectomy anyhow. So what's wrong with scleral buckling? It's massively overdone worldwide. I've done 8,000 of them. I haven't done one in 15 years. It's out of date. It makes the eye, on average, 2.75 diopters more myopic, as Ron Michael showed. It increases forays and tropies by 50%, as Ron Michael showed. And it causes pain, ocular surface disorder because of poor conjunctival closure. It damages the tenons and conjunctiva if they ever need glaucoma surgery. It's much harder to do a trabeculectomy bleb or a tube shunt bleb. The operating times are longer, and it's far better to do a retinectomy instead of the need to support the vitreous space, as people say, with scleral buckling. That's all I wanted to cover at this time. So hopefully that will help you in your reoperation cases.
Thank you, Dr. Charles. That was a great quick take on what to do and, more importantly, what not to do for these three surgeries. So, Dr. Chawla, any thoughts on that?
Professor Dr. Charles, thanks for introducing very revolutionary ideas. I would just like to have a clarification on what you talked about scleral buckling. When you meant about scleral buckling, was it in context to reoperations, or was it in context to even primary surgeries?
Good question. Because in the United States, but it'll happen more and more worldwide, patients insist on emmetropia. They insist on a quiet eye. When you buckle an eye, the encircling element, there's no way in the world you're going to ever get, if you do phaco-vit, you're going to get the refractive outcomes the way they should be. Patients want a comfortable eye. When you do a 360 peritomy and pull the conjunctiva up at 3 and 9, the patients get an ocular surface disorder. When you take the traction sutures on the muscles and rub them across the cornea while you're rotating the eye to put the buccal sutures in, they get epithelial defects, and people scrape the epithelium all the time in these buccal cases. Patients don't want an ocular surface disorder. One of my best friends is a brilliant scientist and attorney as well, and he got a buckle at Vanderbilt. And now guess what? He's got double vision, and because the buckle is acting as a fulcrum or a pulley under his rectus muscles. So patients don't like that. I want to achieve the refractive outcomes, the pain and discomfort and outcomes that you achieve with modern day cataract surgery. And you can't achieve that with encircling buckles. So it applies to all situations, but specifically to PVR, a common situation is someone does a vitrectomy to repair, say, a pseudophakic detachment. It doesn't work because of PVR. And on the second surgery, they do a huge encircling element. And now the patient's 3 diopters myopic, and the patient has a 2-hour operating time with lots of pain medicines post-op. Then they get glaucoma, and the buckle makes it so hard to do a filtering procedure. And it's unnecessary. Simply learn to use vitrectomy techniques to repair retinal attachment. Build your skill sets, build the techniques, and get rid of the scleral buckle. It's an anachronism.
Steve, I agree with you as far as the PVR situation is concerned, and also in most cases where, say, pseudophakic detachments, now almost exclusively we do vitrectomy only. But what about the young patients who present with a primary detachment where the vitreous, otherwise there's kind of intact vitreous, and a simple buckle takes care of their retinal detachment, and why invade the vitreous in those cases?
Yeah, what I do with the typical young myope without a PVD, with the Brits call a round. I shouldn't talk about the Brits on Independence Day, but what they call a round hole detachment. What I do is put in the PFO, attach the retina with PFO, fill it all the way to the top with Alcons perfluoron, laser the brakes. Then I come back in 2 weeks and a gentle PVD has been created by the PFO. So now the patient can stand up, walk around, go to work, fly in an airplane, so it's a great way to fix inferior detachments. And that's how I do it. Now, if it's a superior detachment in a young myope, I understand that I'm not going to make an aggressive PVD and cause more retinal breaks. So what do I do with the superior detachment? I use gas, and I tell the patient, the vitreous is still stuck to your retina. I may have to go back later and remove it, but I'd rather do that than do a big buckle and disturb the eye with scleral buckling. Now, there are very, very few exceptions. I've had patients with an inferior detachment said, I've got to fly in an airplane tomorrow. I can't come back for 2 months. Okay, I put a buckle in. I had a lady that's pregnant with 3 months before delivery, in bilateral infratemporal detachments. I did a segmental buckle in each eye, 15 minutes per eye without any sedation. So there are some unique circumstances, but instead of the young phakic patient, myope, the standard of care being a buckle, we need to move to the standard of care being a vitrectomy.
Dr. Pramod, your thoughts on what Dr.
Question
Cyrus said and Dr.
Yeah, Dr. What Dr. Cyrus asked, that was my question. But also to add on, sometimes you have difficult induced PVD and you have a multiple lattice degenerations peripherally. Again, typically you see these young patients with a detachment, and it may be breaks in a lattice, multiple 2 or 3 rows of lattices where practically vitreous will never separate. And obviously you cannot just do good vitrectomy in that area. We want them to live phakic also. So how you handle this patient without having buckling?
I'm comfortable with inferior detachment using PFO. If it's a superior detachment using gas, and accepting the fact I could possibly have to reoperate if the vitreous contracts later. I'm opposed to aggressive PVD creation that people think is the standard of care in these patients, because they do make other breaks, particularly in the lattice situation you described. So I'm opposed to aggressive PVD, and I'm opposed to buckle. That means I have to accept the fact that on occasion I'm going to reoperate. But when you operate with 25 gauge or 27 gauge, and you're not touching the conjunctiva except for 3 tiny little incisions, it's a comfortable, quiet eye, and it's a small price to pay compared to having a big buckle around your eye for the rest of your life when you're a 20-year-old myope.
How long you would wait? Typically, suppose you have to, do you plan resurgery in these eyes, or you just if it doesn't settle, then only resurgery? And if you plan resurgery, what will be the interval between first and second surgery?
Now, I would never plan resurgery, because many of the cases you can fix with gas alone. So it's not a planned thing. It's a as needed thing.
Is there a time that you wait before you reoperate in a situation because you want the membranes to mature? Often we do, kind of find a situation where within a month after your operation, after a second operation, it is detached and you want to go back. So is there a time when you would,
your point is well taken. The late Steve Ryan coined the term the life cycle of the disease. And it's a good term, waiting until, as you state, the membranes become mature. The late Ron Michaels also did an encircling element, which I wouldn't do, to reattach the periphery, and then did the vitrectomy months later. But a simple way to do it is when the eye's quiet, there's no cells and flare, that's pretty, and outside, there's no conjunctival hyperemia. It's kind of about the time these membranes mature. And that's typically once PBR starts, weeks, not months, but not days. So a couple, 2 to 3 weeks, something like that. So I'm delighted you brought up the point. It's a very important point.
Yeah. There's a question from the audience from Dr. Sumit Kandurja related to retinectomy under air. What should be the IOP setting for doing retinectomy under air?
Except in children and in people with real low perfusion pressure, like with people with dialysis shunts, I leave the interocular pressure set or the infusion pressure on the Constellation set at 45 millimeters of mercury in every case. Now, obviously not in children. Now, when the patients are under general anesthesia, which is unusual, I always tell anesthesia people, leave the blood pressure where it was. Don't make the patient so deep. If you want, we'll add a block, but don't make the patient 70 over 40 blood pressure. Leave it 120 over 80 or above, and that way we'll have sufficient perfusion. But I'd love to have the IOP at 45.
And you mentioned that you favor 1,000 centistoke silicone oil to 5,000 because, as you rightly pointed out, we have also noticed that the emulsification rates tend to be similar. But are there any settings where you would prefer to put in 5,000 centistokes? For example, a very badly traumatized eye, this eye is going to collapse if you don't keep a long-standing tamponade in. So in such a setting, would you consider putting a 5,000 centistoke, or is there any setting where you would?
It turns out that there's a very complex calculation which goes by the name UG, and I wouldn't attempt to try to explain it because I don't fully understand it. But it turns out that the long chain polymer average length, which is what drives viscosity, is a very minor factor in that equation. Interfacial surface tension is exactly the same between 1,000 to 5,000. They're both dimethylsiloxane. It's just that the bell-shaped curve, the Gaussian distribution of average polymer length, is pushed a little bit to longer chains to increase the viscosity. So in short, it doesn't make enough difference. So to summarize, there's no instance where I would use 5,000. It takes 5 times as long to inject, exactly 5 times as long to remove, and operating time counts. It's hard on the patient, and it's not efficient when we're trying to get many cases to the operating room in a day and save labor costs.
Yeah. You also mentioned that from minor, epiretinal membranes and reops of detachments under oil, subsilicone oil detachments, you prefer to have the oil in and then go in directly. But are there any settings where you would say in a non-emulsified setting? Of course, if it's emulsified, you need to take it out. But in a non-emulsified, what are your options? When do you remove the oil completely and then again go in and consider putting in oil again?
There aren't any. Well, there's only one. I'm sorry, and that is the patient develops a cataract and needs a reoperation because of PBR. I take the oil out, do a lensectomy, strip the capsule with the forceps, and then check the retina carefully. Once I've got a good view, if I can fix it with gas, I will. If not, or if it's completely attached, I'll just leave air in there. But if it's complicated PBR, I'll reoperate the PBR and say retinectomy, and then put oil back in. So I only do it to facilitate lensectomy. I'm not a big fan of phaco over oil. Phaco over oil, you end up with a fibrous posterior capsule. You can't yag it. You have to remove it with the cutter, and it's just a nightmare. So if you break the capsule when you're doing phaco over oil.
So do you normally do a sulcus implant in these patients?
No, I don't. If there's oil in the eye, no implant at all. And I mean, a phakic capsule removed, but I avoid the sulcus implant that I used to use because the oil gets anterior to it and ruins the cornea. And the same argument applies to ACLs. I don't use anterior chamber lenses in that setting. Now, if you ultimately get the oil out, which hopefully we could do more in the future, but in many cases the oil has to remain. But if you get the oil out later, then I'll do a Yamani procedure or have our anterior segment person do that. I very much like that procedure.
All right. So there's a question from Dr. Abhishek Agarwal from Sri Ganganagar. How do you manage retinal slippage and how do you avoid it? And retinal folds after retinectomy more than 90 degrees? In
giant break cases or just retinectomy?
Retinectomy.
Okay, frankly, I just don't see slippage in the retinectomy setting. I mean, it seems to suggest an inadequate membrane peeling was done before the retinectomy. But on the other hand, why do I call it incremental retinectomy? You can't anticipate. Why don't I do it under saline? Because I don't know how much I need. And so with fluid air exchange and internal drainage, that you've got the retina almost reattached, and you make a little cut. And you say, "Oh, the retina is attached. I'm done." Then you say, "Oh, no, I need more. I need more. I need more." Now the retina is attached. So if you do it under air, that surface tension helps you avoid slippage for one, and because you're removing subretinal fluid and infusion fluid simultaneously with removing retina that you must remove with membrane detached, you just get a better result. You're doing the right amount of retinectomy.
Dr. Steve, just one more question here. Now, to under air, when you do retinectomy, initial cut, do you use a cautery? I missed probably that part. Or you just start directly cutting with your cutter, and you said you use a laser over the blood vessels, right? You try to avoid diathermy there.
What I don't use the diathermy. I'm not opposed to the use of the diathermy. There are times when I've regretted not using it to large vessels. But what I normally do is I just start with the cutter, as you suggest, and then I raise the intraocular pressure if any bleeding occurs. Then when I go back to laser the edge of the retinectomy, I also laser the vessel that bled, and then I lower the IOP.
What is your optimal time of keeping the oil in? You know, is it 3 months, 6 months, or what? How do you determine when to? You know, is there any time that you put? Minimum 3 months, I would leave it in, or what's the magic
Unfortunately,
number?
there's no science to answer that question, and I find that a very challenging question. When the retina looks wonderful under oil, and we all know that when you remove it, you think you've got everything sealed up. The retina looks wonderful. You take the oil out, and the next day they're detached. That happens enough that frankly, superstition starts ruling your behavior, and you say, "Well, let's leave it another month. No, let's leave it 2 more months." There is no scientific answer to that, and it's frankly our biggest frustration. Now think about what happens when you do a vitrectomy. You've permanently reduced the viscosity 800-fold. You can't get a subclinical retinal detachment in a post-vitrectomy eye. That's why buckles don't work in a post-vitrectomy eye, because you got an 800-fold viscosity reduction. And so the fluid runs through the tiniest little pinhole that's virtually invisible. And that's why you have this substantial reattachment rate. It's not just PVR recurrence or failure to remove membranes. It's tiny little holes that are challenging to see. Now, so what do you do about that? What's the conundrum? If you say, well, I'm going to make 27 rows of laser, the problem with that is that now you've got, well, we've got somebody's slides up.
Subhendu, can you just stop screen sharing for a minute?
Yeah. So now what do people do that are worried about that? They do a trillion rows of laser, and remember that PVR is a keloid. It's Mueller cell reactive gliosis, but it's functionally a keloid. It's excessive healing. So if you do too much laser to avoid the post-op leak problem, you engender PVR in epimacular membranes. And but if you don't, then a little pinhole can cause redetachment. So I think one of the things to come to grips with for all of us is occasionally we have to reoperate, but instead of this notion of instant reop, where you do a horrendous big scleral buckle phaco-vit with 8 trillion rows of laser on the first procedure to avoid a reop, and have a 3-hour operation, and the patient takes pain medicines for a week, and it's got outrageous refractive outcomes. Why not do the minimally invasive surgery to get the retina attached? And if you have to reoperate, I've had patients I've had to operate 6 times, but they're ultimately attached, no ptysis, no hypotony, and no pain.
A quick question.
I definitely agree to your thought on this about pinhole breaks. There are cases where there is a buckle all around, there's silicone oil in situ, and you see a pocket of fluid at one place. And when you investigate that area by either a big imaging on a viewing system like Claris or like Optos, and then when you go in, you realize there's a small pinhole break sitting there. It's very often.
Absolutely. I agree.
Yeah.
I have a quick question to Dr. Charles. I like the term incremental retinectomy. So when you do 270°, the rest of the retina is still fine. Or in cases where it is still attached, how would you go, and what's the rationale of arriving at 270 as complaining it to 360, Dr. Charles?
Actually, it was on one of my slides, but I didn't mention it. If I get to 270, I go ahead to 360 because my experience is that if I'm only 180, the inferior 180 is the most common one, I leave it that way. But once I get to 270, I said, okay, that remaining quadrant's going to contract post-op. I may as well go 360. I said that on my slide, but I didn't mention it verbally.
So if it's 360°, how do you prevent the auto rotation of the macula? It rotates on itself.
I'm sorry, I didn't catch that one.
So if it is a 360° retinotomy, how do you prevent the rotation of the macula? You know, the optic disc acts like a fulcrum and the retina rotates. So the macula is ectopic after.
I think if you do retinectomy under air, I don't see this rotation as much as other people who talk about. If you do it under fluid, then you can get rotation. But if you do the retinectomy under air, I don't see the slippage rotation problem people talk about.
There's a question from Dr. Ashok Natraj from Trivandrum. How do you control bleeds under retinectomy edges when you're operating under air? How do you manage it there?
How do I manage bleeding? Is that the question?
Yes.
Raise the interocular pressure and use laser for hemostasis. We've obviously for years now used 532 nanometer laser, which is green, hemoglobin's red. So it's ideal for hemostasis because it doesn't cause damage to all the surrounding tissue. It only absorbs energy in the blood column.
Yeah. So the operator, what is you do not use diathermy, and this is situation too. Okay.
I mean, it's not bad to use it. It's just another step. If you're going to laser the edge of the retinectomy anyhow and laser retinal breaks anyhow, why not use it for hemostasis as well? And in diabetics, it's particularly important. When you do a diabetic traction attachment, diathermy is simply a mistake because you'll cause wider spread necrosis than you realize. And then a year later, there'll be a round hole and you'll say, oh, it's atrophic, it's ischemic. No, you made it with a diathermy.
The question from Dr. Chitranjan Mishra from Madurai. Is there any increased risk of glaucoma that you've noted if lensectomy is done and tamponade used and then a scleral fixated IOL done at a later date?
You can't do a scleral fixated IOL if oil remains. So you've got to get the oil out. And I don't think that the scleral fixated IOL, specifically the Yamani procedure, I don't do the adhesive bonding technique. If you do, and I never suture the iris, I think that's a big mistake. It causes inflammation. So no, I don't think that the Yamani causes glaucoma. Now, use of subconjunctival steroids, which we all do, does cause that. So years ago, I used to use triamcinolone subconjunctivally in virtually all the patients, and I've long since given that up and use only Decadron, because with Decadron, you have a higher immediate dose, but much shorter durability, and therefore you're not as likely to cause steroid glaucoma.
Thank you, Dr. Charles. That was a great session, and I think we could go on for an hour, taking questions and discussing this very challenging, very pertinent topic. But I think we'll move on, and it's my pleasure to invite our next speaker, a close friend and a very talented surgeon, a multi-award-winning surgeon, Dr. Subhendu Boral from the Disha Eye Hospital, who's going to talk to us on something that he does, and it's very interesting to see his videos, RP choroidal transplants for choroidal neovascular membranes. So, Dr. Subhendu.
Thank you, Anand. Thank you, VRSI, for organizing such a beautiful webinar on this auspicious day after a beautiful and very interesting talk of Professor Steve Charles. This is my topic, autologous RP choroid graft transplantation. So we know the principal causes of CNVM. It is AMD, PCV, and myopia. And the indications for surgical removal of CNVM are, if it is, I don't operate on the isolated CNVM cases. Usually, if it is associated with the large, markedly elevated, long-standing submacular hematoma, RP tears, hematoma not responding to the previous treatment, like subretinal injection of subretinal TPA, or hemorrhagic retinal detachment directly, like from ORA to Rocereta. And autologous RP choroid full thickness transplantation is I am preferring in long-standing cases if it is persisting for more than 8 weeks. So the beneficial effect of CNVM and submacular blood removal or the removal of the choroidal neovascular tissue, actually it completely removes the possibility of the rebleed, as well as removal of the barrier and toxic amount of the submacular blood. And rationality of the autologous RP chloride graft transplantation, because the RP is already, there is extensive damage to the photoreceptor as well as the RP cells in long-standing cases. And by providing the autologous graft, you are providing healthy autologous RP cells, and vitrectomy subretinal TPA with or without subretinal which may not work, and functional improvement may not be possible in these cases. So these are the simple like surgical steps. So I will come one by one, step by step. First of all, induction of retinal detachment to remove CNVM after doing cautery to the peripheral retina. You can do cautery, you may not do cautery because the peripheral retina is less vascular. After doing cautery to gain access to the subretinal space, I'm injecting BSS subretinally with the help of 38 gauge or 41 gauge cannula. Either it is polytip or metallic cannula. You can just lift up the neurosynaptic retina from the from the RP in a blob-like manner in multiple places, and you can do multiple times fluid exchange to unify it, and then can do do the retinectomy to gain access to the subretinal spaces and come to the subretinal space. So if the retina is already elevated, like in this case, temporal 6 to 7 o'clock retinectomy directly you can do without elevating the retina because the retina is already elevated. And as soon as you do the retinectomy, gas of blood will come out and do that surgery under ears. And then that it is time to remove the subretinal blood. Sometimes subretinal blood is very much like thick and clotted, so it is very difficult to remove the blood completely from the subretinal space. After removing all kinds of blood, you can just remove the subretinal neovascular tissue. And let me tell you one thing, that this neovascular tissue is sometimes very thick, just like nuclear remnant. You have to use frag settings using high suction and very low cutting rate. Now, sometimes this neovascular tissue are very fleshy. You can see the fleshy neovascular tissue. I'm removing it with the help of ILM forceps and with the help of this DDMS also, and remove the subretinal residual blood and do some gentle cautery to the feeder vessel to prevent the postoperative rebleed. Now it's a time for autologous RP chloride graft transplantation. After removing all kinds of blood, inject PFCL to keep the retinal flap away from your working area. And in this case, particularly in this case, there was associated chloride detachment. The case become easier for me because I am using cutter to lift up the graft from the surrounding choroid and translocate this graft under the PFO into the proposed site of the fovea, whatever it is there, and you have to remove the silicone oil, you remove the PFCL after placing the graft, and then again inject the PFCL to settle the retina, do fluid exchange, and do laser after removing all kind of wounds, and after doing all 360 laser barrage, and treat it as a GRT, like taking care of the cornu cases. And do after removal of the PFO, you can inject the silicone oil 5000, and post-operatively patient is recently doing okay. So this is another case where after removal of the all kind of bloods, I'm injecting PFCL and choosing an relatively healthy looking area of RP. So did the cautery, little bit of cautery, and using bimanually with the help of Kurt's scissor, I'm cutting the graft under the PFCL. I'm just translocating the graft. Harvested graft into the proposed side of the fovea. Graft realignment was done. Then you have to remove the PFCL and again inject the PFCL over the disc, and so that, and start doing fluid exchange and do laser, and finally silicone oil PFCL exchange, injecting silicone oil with the left hand and removal of the PFCL with the right hand under Chandler's light. So this is another case where I'm injecting PFCL to remove, keep the retinal flap away from your working area, doing some kind of gentle cautery, not too much of cautery, not too much of shrinkage of the graft is required. Now you can see the nicely graft has been taken from the place with the help of cutter as well as the forceps. So under the PFCL with the help of forceps, I'm translocating the graft into the macular area, up to the macular area, then remove the PFCL, and again remove the PFCL and inject the PFCL over the disc, starting from the disc to reoppose that flap, retinal flap, and start doing fluid exchange as well as the laser. This is another case. It was very interesting thing. I previously treated the case with the help of vitrectomy with subretinal TPA, in this case of subretinal blood non-drainage technique. But after 14 weeks, the patient came with the massive recurrent subretinal hemorrhage. So in this case, I inject the TPA and then did the retinectomy and removed all the blood. The blood was still clotted. Although I waited for 20 minutes time, but still the blood was not lysed properly. So you have to be very careful because a lot of adhesions can be there between the retina and the scar tissue. So you have to be very careful not to avoid the macular break, and finally remove the silica, this CNVM, then injecting the PFCL to keep the retinal flap away from your working area. And under the PFO, I'm just doing the cautery into the relatively healthy looking area, taking the large graft bimanually under the sandbler slide. And bimanually, we are shifting the graft considering its upside down manner and up to the macular area. And then graft realignment was done. Then remove the PFCL completely from the subretinal space. Then inject it again, just like managing GRT cases, inject it directly from starting from the nasal side of the retina, and then it is retina is looking nicely, and posteriorly patient in a good vision, like 6/16 vision from PR inaccurate stage. So coming to my experience, so this was a large submacular hematoma with vitreous hemorrhage, and postoperatively patient was doing okay after silicone removal. 53 months follow-up, patient gained 6/36 vision. This is another case, vitreous hemorrhage with the whole subretinal blood. Finally, patient gained 6/60 vision, logMAR 1 after 9 months of silicone removal. You can see that graft is gradually becoming incorporated into RP choroid complex. This is another case, old submacular hematoma with vitreous hemorrhage. The graft is nicely placed and graft is gradually incorporated into RCC complex. And this is another case, cataract with large submacular hematoma, but occult CNVM. But unfortunately, the patient developed a lot of excessive scarring subretinally going, and patient was having low IOP. That's why silicone removal was not done even after 6 months of surgery. This is another case, hemorrhagic retina detachment. Graft was doing okay, and it was USG also, ultrasonography also you have to do, and to identify how much the hemorrhagic detachment is there. And this is another case, hemorrhagic retina detachment with large CNVM. Patient was doing okay, but still the IOP was not raised. I used silicone 5000 centiloid in these cases. And functional improvement you can judge from that multifocal ERG, although I have not done that microperimetry, but still multifocal ERG showed some kind of waves in all cases. And anatomical success, you can see the ICG showed revascularization of the translocated graft as early as 2 months. It can happen if sometimes before 1 month also. Thank you.
Thank you, Subhendu. Fantastic surgeries. Dr. Charles, your thoughts on this surgery?
Well, this surgery is magnificent. I have no personal experience with it. I've done a number of cases in pig surgery where we do induced pluripotential stem cells at the National Eye Institute and build an RPE on a biodegradable scaffold. So from doing that work, I've learned from the 50 scientists on our team at NEI that the peripheral RPE doesn't support the macula, that the peripheral RPE is the wrong kind of RPE for the macula. The late Bill Tasman many years ago reported that in ROP, ectopic maculas lose vision later in life, drops down to 2200, 2400 without any new ischemia or scarring or anything else, simply because it's the wrong pigment epithelium. So there's a fundamental difference between peripheral RPE. There's some people in Europe that were doing iris RPE, which doesn't even support the visual cycle. So just because it's pigmented and just because it's there doesn't mean it works. And so that's one point. Second point is I've heard that others who have done the procedure that you outlined have a fair incidence of PVR. Carl Kleiss is an excellent surgeon, carries these the retinectomy all the way to the aura like you did, and he states, and he's honest, that has less PVR than if you make the retinectomy somewhat more posterior. But again, magnificent surgery. I'm just the long-term visual outcomes is the question.
My only concern is the PVR incidence, Dr. Subhendu. What do you feel is the PVR incidence in your series? You've done a substantial number of cases, and how do you manage it?
Till now, I did more than 10 cases, so 11 cases, I think. Yes, And one case there was a development of retinal detachment. In 3 cases there was persistent hypertony, maybe because of exposed RP choroid area. That's maybe I did the retinectomy a little bit posteriorly. That's why it's not at that level of Oda Serrata. Just Dr. Barbara Padolini was describing her technique. That was the situation. Otherwise, recurrent RD not developed. It is the PVR in one case detachment happened, recurrent RD, and ERM formation happened in 2 cases. That in those cases I removed the oil and ERM formation. That's all.
Just one question from Dr. Charles. Where retinectomy is desired, what is your gauge preference? 25 gauge or 27 for a more controlled retinectomy? Because we are using 25 gauge mostly. Yeah.
I use 25 gauge. I've done several hundred cases with 27. It works fine for me, but I train fellows, and I find that the fellows have a tendency to bend the instruments to 27 gauge, and they of course the wound leaks are very rare anyhow, but less with 27 than 25. So if I didn't train fellows, I would use 27, but I do train fellows, so therefore I use 25.
There's a question from Dr. Chitranjan from Madurai. How do you measure the size of the graft? Do you have any, ballpark figure, or is it an estimate, or do you do anything specific?
There is no telltale criteria for estimating the. For me, Anand.
Yeah, sure. Yeah, for
There is no criteria. This is not standard criteria to measure the graft size. You have to judge it from the size of the CNVM. It is very large. Then I am used to do, because until unless is very large, there will be very large CNVM having very large kind of RP loss. So you have to take the larger graft. And if it is very small CNVM, though, so you don't have to use too much of cutter during the removal of the CNVM. That means small size of CNVM is necessary. So that you can only judge it after removal of the CNVM only. Yeah. So CNVM, because it is, if it is large, then large size. So on most of the situation, large CNVM are present. So that means the large size graft is necessary. And size of the graft, you can see it is 3 by 2 or 3 by 4. That size you can judge from the size of the disc, 1.5 millimeter to 3 times or 2 times, 2.5 times.
So yeah, my only comment, terrific surgery.
Anand, can I make an observation?
Yes, please go ahead, Dr.
Someday when we're talking about the gauge, I was just mentioning in some of these cases, the blood is so dense and thick, and also the membrane, sometimes the CNVM is so tough that in these cases, sometimes we prefer to use 23 rather than 25, just because the 25 tends to keep getting blocked. And so sometimes we prefer, in these cases specifically, we say, let's use 23 rather than 25.
Yeah, my initial cases are on 23 gauges, sir.
Right.
Most of the cases are done in 23 gauge, not in 25 gauge. 25 gauge last 3-4 cases, 25 gauge. No case I have done it in 27 gauge, but most of the cases by 23 gauge.
27 gauge, the bending is the issue.
Yes.
So my only comment here was
because most of the time the blood is completely different from the diabetic vitreous hemorrhage. Yes, they're very sticky.
It's leathery.
Leathery, and it becomes that cannula gets stuck with the cutter. It insinuates between the cutter and the cannula inside, and so it will be stuck. You cannot go inside, so you have to go out and inside and then go out, so that you can remove the you can loosen your cutter from the cannula.
Actually, very often I've had to actually use a forceps and remove it completely. It's almost like it's as bad as cutting and doing a lensectomy.
Yes.
So my only comment here is that perhaps you need to actually move it right to the absolute periphery, as Dr. Charles also mentioned, to avoid PVR. So thanks, terrific presentation. We could go on this, but the constraint of time, we have to move on. Could you please stop screen sharing?
Yes.
Yeah. It's now my pleasure to call on a very young mercurial dynamic surgeon, Dr. Srinivas Joshi, from the M.M. Joshi Eye Hospital. Again, he's another surgeon who's won a slew of awards around the world, and he will be presenting his experience on retinal grafts for refractory macular holes. So, Srinivas.
Thank you so much, Anand Rajendran sir. Good evening, everyone. My regards to the President, Dr. Shobit sir, and Dr. Muralidhar sir and Dr. Raja sir and entire team of VRSI along with the panelists and Dr. Steve Charles. So I'll be presenting a few set of cases in large and refractory macular holes. So I have a pre-recorded video. Is it playing?
Anand, it is echoing.
Is it playing now?
No, it's not playing. It's static.
Yeah.
Playing now.
Echoing.
But the volume is low. The voice volume is low.
Okay. Damage the choroid of the RPE. And bimanually, I tried to cut this retinal graft.
Fine.
Yeah, it's
fine.
working okay now.
And
Playing,
then
playing.
place it over the MAC hole.
You can restart it to the beginning.
That PFO over the MAC hole. Actually, this was my first surgery when I tried it under the PFO, under the refractory macular hole. And the results were quite satisfactory. And that is what made me to go ahead and I have done 15 cases till now. So this was a failed MAC hole case. Answer, let me know if you're able to hear the audio.
I think you've muted the audio. Are you playing it off your laptop? Then you need to narrate or you need to run it at a louder volume.
Okay. The first one was heard.
I think it's better you do the narration.
Yeah.
Narration?
Just do the narration. Just keep talking as you're observing.
Okay. So finally, the MAC hole was closed in this case. It was a third attempt. The first attempt was the Pyrma ILM peel, which did not close. And the second one was inducing a retinal detachment. And finally, we resorted to the neurosensory retinal graft technique. So this is my next case. I don't know, it's not playing. Sorry for that.
Srinivas,
Yes,
just
sir.
directly present from your slide view, not from the full screen view, from the slide view. Share your screen and
It's
directly
not
present
presenting a PowerPoint, it's a MP4 video.
Oh,
It's a full complete video.
It's a video present. It's not a PowerPoint.
so there should not be any problem.
You stop it and restart it again. Or tell Sai to play it from his end if you have a backup there.
Sai, can you do
Sai,
that?
can you just play his video?
I'll do it, doctor. I'll do it.
Good evening, everyone. At the outset, I would like to thank entire VRSI team and specifically Dynamic Scientific Committee Chairman, Dr. Anand Rajendran sir, for this opportunity. So I'll be presenting cases on neurosensory retinal grafts. So this was a case of persistent MAC hole where the ILM peeling was done before and it failed. So the patient was referred to our institute. So the only option left to me was to go ahead with the neurosensory graft technique. So after cauterizing it well, I usually use a 42 gauge needle to create a bleb so that I should not damage the choroid or the RPE. And bimanually, I try to cut this retinal graft and then place it over the MAC hole and then slowly inject PFO over the MAC hole. Now you can see the graft placed over the hole well, lasering the primary site where the tissue was taken, and you can now see with the IOCT the graft placement placed well. Careful fluid air exchange was done and silicone oil was injected, and the patient improved to 6/36 from 3/60. So this is another case of large MAC hole of more than 1076 microns. Here again I went ahead and tried to cauterize the area where I have to take the graft, and again you can see the nice blister coming out here. And bimanual technique, using the forceps in left hand and the curved scissors in the right hand, I placed it over the MAC hole, injected PFO. Sometimes these retinal grafts can get attached to the forceps and it gets slipped. So I regrasped it, removed the PFO, and in the second attempt I could place it over the MAC hole. Then I thought everything was done. Let me laser the primary site area, but now you can see the graft moving slightly here and there. I brought it again over the hole, and when I was doing a fluid exchange and removing the total fluid over the posterior pole of the graft area, I could see this graft dancing here and there. I thought something is not right, and I could see some vitreous strands there. So the PVD was not completely induced, so I held the graft in the left hand and finally induced the PVD with a cutter. And now we can see after inducing PVD it was sitting out pretty well. Fluid exchange was done. Now we don't see the graft moving at all, and silicone oil was injected, and it has a very good MAC hole closure with 3 lines of improvement. So this is another case of traumatic MAC hole, where the basal diameter was 1800 micron and minimum linear diameter was 1500 micron. So after inducing PVD, I cut the retinal graft and placed it over the MAC hole, because the hole size itself was around 1600 micron, and PFO was injected over it, and with the help of the forceps I tried to place it. I centered the graft on the MAC hole, and we can see good anatomical closure, and the patient had 1 line vision improvement in this case. This is the another case where it was primarily the MAC hole RD, but MAC hole didn't close in spite of doing the extensive ILM peeling. So I had to remove the silicone oil and then again repeat the same procedure, where placing the graft over the MAC hole and putting a PFO and slowly sliding it over the MAC hole. Fluid exchange. Now you see sometimes if we try to do it more faster, the graft can move into the cutter. So judicious fluid exchange is very essential in this graft, and while placing it we have to allow the silicone oil to fall over it, and we can see the nice graft closure, and the patient had 3 line vision improvement. And this is operated very recently, where the patient had ILM peeling done before, but it caused MAC hole later on, and now you can see I just slided it under the PFO. So now we can see in the post-op the graft settling well and getting integrated into the retinal tissue. And this is my last case. This is a case of primary PDR. It was a simple case, but over 8 to 10 months the patient developed secondary hole because of the reproliferation. After initial surgery the patient had 6/9 vision improvement, but because of pandemic he did not come back. His vision dropped to 660, and we could see the reproliferation of the membranes here, probably was because of the MAC hole, and I had a small bleeder there. Probably if I had cut it or with a cutter or with the scissors that would have been better, but nevertheless I went ahead and put a PFO to stop the bleeding, and I chose the site where there is less blood vessels, and bimanually I tried to take the primary graft And again, you can see I slided it under the PFO. But here the blood was a little bit messier here, but I was happy because some authors have even described the autologous blood transplant for the closure of the MAC hole. And here the graft was sticking well, probably because of that blood clot. And to my surprise, the patient actually improved to 6'9". He's a one-eyed patient and he's very happy. This is the final fundus picture. Thank you very much. Happy Independence Day. Jai Hind.
Thank you, Srinivas. Lovely set of cases. These are really challenging cases. My Dr. Steve Charles, your thoughts on this? You also do neurosensory grafts. What are your thoughts on this technique?
I've done 70 cases. We learned this, of course, from Tamir Mahmood. There's a couple of things I would do differently than the technique that was shown. One, I never use diathermy around the donor site because that means the rim of tissue you're transplanting is necrotic. So I only would use point diathermy. Try to pick a place where, as he said, with no vessels, but then do point diathermy if say 1 or 2 vessels cross it, but not a ring of diathermy around it. I make the bleb at the donor site with viscoelastic because then it's sustainable and you don't need to use bimanual technique. And then I put the PFO in and I cut the graft almost completely with a little tab left. Then I put the PFO in and I've dragged this over under the PFO. So I never have all that dislocation problem you saw on the other slides. And then I never exchange for oil. Oil has a very low oxygen extraction ratio, whereas PFO carries more oxygen, 3 times more oxygen than hemoglobin. So I leave the PFO in for a week. Tamara Mahmood, Barbara Parolini, and Ken Donoso and others that are part of our art study group have all converted to my method of leaving the PFO in for a week instead of exchanging for oil, so that you then oxygenate the graft from its anterior surface, not just from the chorocapillaris.
Can I ask you a question, Dr. Charles? What is the location of your graft harvest? Is it so much posterior or is it a little more anterior?
As posterior as possible, because I want some cone or photopic content from a cellular perspective. Tamra Mahmood's original idea was to get it peripherally, thinking that Mueller cells were retinal progenitor cells. That's only true in fish, has not been shown in mammalians. So I don't buy the Mueller cell retinal progenitor cell context. So I want posterior. Now, one of my best cases ever is actually a lady that was originally from India that had a confluent PRP in both eyes all the way to the arcades. And she had a 4,000 micron macular hole in one eye and 3,000 in the other eye. And I transplanted immediately temporal from the macula. So it looks like a double barrel macula. Outcome 20/60 in one eye, 20/80 in the other eye.
That's a very interesting thought, really. So any of the other panelists?
I had a question to Srinivas. When you're transplanting the graft, is it important to maintain the size, the side, upside down, or do you make sure that you keep the photoreceptor polarity intact?
Of course, it's important. If you see in my initial, when I was doing the surgery, I used to inject PFO on it. And as Dr. Chal mentioned it, it's always better to cut it under the PFO and just slide it so that these retinal grafts might not slip. As you saw in my second case, that slipped off. So to avoid that, you can always cut it under the PFO and then you can just slide it. And I learned it after doing 2 or 3 cases, and in the rest 10, 15, 12 cases, I have just slided it under the PFO so that you will not get it. And secondly, when you sometimes, of course, some authors might disagree cauterizing the edges, but when you cauterize it, we take it from inside. We don't take the cauterized edge. So at sometimes that also acts like a mark over the retinal surface. And even if it slips, you will get to know which area is cauterized. So that also might help. Some have used even the stain also, using a BBG or any stain to see which area you get the stain. And even if it slips, then you will definitely get to know which side is up and which side is down.
I want to clarify one point. I don't cut the graft under PFO. What I do is cut the graft except for a tab, just a tiny part. Then I inject the PFO on the top side of the graft, so it's flapped up like a horseshoe tear, and then I break the tab with the forceps on the leading edge and drag it to the site under the PFO, and that works the best for me.
Yeah, you leave it like a hinge, Dr. Charles, and then
like
put the PFO. Yeah, like a hinge. It's actually the better. So you can just leave a small hinge and then inject the PFO, because I always used to feel cutting it under PFO is very difficult, because you have to lift, and to cut is difficult. So it's always better to do it without, because when you create a blister, when you detach the retina and you inject PFO, it flattens down. So it's always better to just.
But if you make the bleb with I make it with Probisc instead of making it with saline.
BSS. Okay. Okay. So that might probably stay if you inject whisk inside. Yeah.
I have two questions to Srinivas.
Yeah. Can I just ask a question?
Yeah.
Yes, sir.
Srinivas, do you have any experience with the AMG technique, the amniotic membrane graft, and have any of the panelists or Dr. Charles
Yes.
have a comparative this thing of AMG versus the?
Yeah, it was first actually described by Stano Rizzo in the recent ASRS meetings, but my concern is it causes scarring. You know, even sometimes I've seen the inverse ILM peel also causing scarring, in the subfoveal scarring. So AMG definitely causes more and more. It is good for the anatomical closure when you don't have any ILM flaps, or when you don't have any of these, that it's good for the anatomical closure, but we hardly see any good visual improvement in the AMG in my perspective.
I agree 100%.
I have done AMT cases.
Yeah, just let's have Dr. Charles's view.
Yeah, I agree. I do not use either the inverted ILM flap because it's acellular tissue, and I want neural tissue there. It's clear that adaptive synaptogenesis occurs. It's clear that if you do microperimetry, that they fixate within the tissue when you use what we now call ART, autologous retinal transplant. If you use amniotic membrane, it can create more scarring. But there's not evidence of better visual outcomes, and there's the risk of contamination. And in our country, it costs more money. You know, your own retina is free.
Absolutely.
One question I would like Dr. Steve Charles, Srinivas, and the panelists to clarify, and Anand, where would this procedure fit into the armamentarium, and what size of macular hole as a primary procedure, not as a secondary procedure?
Yeah, that's a great question. And of course, there's, as usual, the controversy around that. The paper from England, from the National Health Service, from David Steele and others, and from Scotland, showing that wide ILM peeling all the way to the arcades works quite well. And I certainly agree with that. So that can be used up to, say, 700 microns or so. But once you get beyond, say, 700, 750 microns, then I'm going to the macular patch graft, which now Tamara Mahmood and our study group calls ART for autologous retinal transplant. We always called it the macular patch graft early on.
Yeah, I also agree. This is something which we should probably leave it to refractory macular holes or very extraordinarily large size macular holes. I would say even beyond 1,000 microns.
Exactly.
To that extent, there's another question from the audience. How would you size your grafts? Would you place it right exactly over that, or a little larger? My feeling is a little larger because it's tend to shrink. So Dr. Charles,
100%. You must make it larger. They absolutely shrink. This idea of using a tree fine of some type and trying to cut it exactly to fit is a mistake. It will shrink and you'll have a gap around it. If you're going to achieve adaptive synaptogenesis, you've got to have overlap because of the shrinkage. No question.
I totally agree, because it's always better to have at least 500 microns larger than the MAC hole size. So the only challenge is to accurately measure it, although the tree fines actually does it. But the disadvantage with the tree fine, as beautifully shown by Dr. Rupakanti Biswas, is you need a 20 gauge entry into that. That's the only larger entry you have to do with a tree fine. We don't get it with a 25 gauge. So that's the only challenge. Otherwise, if you have the exact measuring, it's well and good. But I always prefer to have a little larger, not very large, a little larger. As you rightly said, it definitely shrinks.
Terrific.
I have a question to Dr. Srinivas.
Last question. We're kind of running behind.
Yes.
Yeah.
Like, have you ever used the gas, or in all cases, silicon oil?
Sir, very good question. Actually, I prefer more of gas than oil. But once it so happened that the patient did not position properly, and the next day when I saw it, it had slipped off. So in those cases who are not very compliant on positioning, because positioning is very key.
If he is compliant, then
if he's compliant, then you can go ahead with the gas, sir.
Yes. Okay.
So we are absolutely out of time. Sorry, one quick comment by Dr. Charles.
I was just going to say the medium-term PFO solves that problem. You got to go back in a week or 2 weeks actually and take it out, but it works every time and they never slip, and it oxygenates the graft from day one.
Yeah, I agree. But the only thing is slightly expensive in India, Dr. Charles. So the economic concerns of the patients is also important sometimes.
Sure. Thank you, Srinivas. Thank you, everybody, for wonderful comments. We'll now move on quickly to our next speaker, Dr. Sangeet Mittal. He's a very celebrated surgeon, very experienced surgeon. Again, somebody who's won a lot of awards. He'll be talking to us on managing retinal detachments with staphylomas breaks. Sai, can you pull up his video, please?
Thank you, Dr. Anand, for including me into this symposium.
Pleasure.
I've asked to play the video.
Yeah, Sai, please play his video. Yeah.
Type 3 staphylomas are primarily peripapillary staphylomas. These type of staphylomas are commonly associated with retinal breaks and retinal detachment. Breaks usually result from increased antero-posterior traction and weak adherence of retina with RPA due to chorioretinal atrophy. These breaks are difficult to manage as they lie in the staphyloma and laser is not possible around these breaks. Inverted ILM flap technique has been described to close large macular holes and optic nerve head pits. In this video we will demonstrate the use of ILM flap in the management of breaks associated with type 3 staphyloma. First case is a 43-year female who presented with sudden decrease of vision. She was diagnosed to have retinal detachment with optic disc coloboma, peripapillary staphyloma and choroidal coloboma. 25-gauge pars plana vitrectomy was performed. PVD was induced with the help of triamcinolone. PVD induction is done carefully as vitreous is quite adherent to the edges of coloboma. A retinal break was detected at the edge of peripapillary atrophy inferior to the coloboma. A communication between the vitreous and subretinal space was noticed. ILM flap was used to cover the juxtapapillary break. Laser was done around the optic nerve head and the flap was stuffed inside the break. Fluid air exchange followed by gas tamponade was performed. Post-operatively, retina was attached and the patient regained best corrected visual acuity of 6/18. Second case is a 38-year highly myopic male who presented with decrease of vision for 2 weeks. He was diagnosed to have retinal detachment. His best corrected visual acuity was 5/60. 2 breaks were seen at the edge of inferior crescent inside staphyloma and a communication between vitreous cavity and subretinal space was seen. Posterior drainage retinotomy was done to flatten the retina. ILM flap was raised to cover the juxtapapillary breaks. Due to nasal location of breaks, it was not possible. PFCL was used to stabilize the posterior pole and a free ILM flap was used to stuff the retinal break. Second retinal break was also closed using another free ILM flap raised under the PFCL bubble. Fluid air exchange was done and laser was done around breaks. Air was replaced with 12% C3F8 gas. Post-operatively retina was attached and the best corrected visual acuity was 6/9. Next case is 64-year female. She was diagnosed to have recurrent retinal detachment with PVR in left eye. She was high myope with myopic degeneration and scar in the macula. Her vision was perception of light with inaccurate projection of rays. Pre-retinal membranes were removed. Breaks were seen in posterior staphyloma. SRF was drained through posterior breaks and retina was flattened. Free ILM flap was stuffed in the posterior retinal brakes. PFCL was used to stabilize the posterior pole. Relaxing retinectomy was done to release anterior PVR. 360 degrees barrage laser was done and PFCL was exchanged with silicone oil. Laser around the optic nerve head was not done and neither was possible in this eye. Three months post-operatively silicone oil was removed, retina was attached and the best corrected visual acuity improved to counting fingers at 1 foot. These are pre- and post-operative pictures of few other cases managed with same technique. To conclude, it can be said that retinal tears may develop in areas of chorioretinal atrophy associated with colobomas or staphylomas. Free ILM flap may help in closure of such holes, where laser is not possible.
Thank you.
Thank you very much.
Thank you, Sangeet. Terrific surgery. Dr. Shobit, your thoughts?
Yeah, where you had the nasal break, Sangeet, very innovative technique, excellent videos also. But where you had the nasal break, could you have taken a nasal ILM flap and flapped it, a hinge flap?
Sir,
Or is it technically very difficult?
Yeah, it could have been very difficult. When I started the case, I thought I'll be able to cover with this flap, the hinge flap. But unfortunately, I could not reach that area. So then I already have made, yeah, and so I just freed it and then just stuffed it under the PFCL. PFCL generally stabilizes the posterior pole environment, and you can easily do the
It's always better to peel under PFO.
Yeah.
Any thoughts, Dr. Charles?
Yes, two. One, I thought the surgery was elegant. I thought the video was phenomenal. The only difference is that I would always use brilliant blue, not ICG, because of the known toxicity of ICG. And the only other comment is that I would not make a ring of laser around the optic nerve head because of the risk of nerve fiber layer damage. I would, even though the visual outcomes that you presented were quite good, I would specifically treat an identified tear if I could. But I think the ILM flap is a superb idea.
Because used in the case, it was like very poor contrast. I tried to stain it earlier with the brilliant blue, but could not get a good stain. I used the ICG because it was a very highly myopic eye. There was a lot of myopic degeneration and a scar there. I got a better contrast using the ICG. Earlier cases, I was not sure, so I did the laser around the optic nerve head. But later on, I realized that the laser really does not help in these type of cases. So now I have stopped doing laser around optic nerve head.
Can we have some views from Dr. Pramod Bhende, please?
You're muted.
Dr. Pramod?
Yeah. This is, I think, a very elegant and excellent surgery. I mean, not much to add. Basically, the problem, another what we repeat sometime, what I was have my doubt about, you have a staphylomas where you absolutely no RP choroid, break sitting right there, not really, maybe macular hole, may not be macular hole as such, and where you just cannot get laser reaction. How we would handle type of situation. ILM peeling also is not that easy. They are deep set eyes. Reaching that area post staphylomas base is very, very difficult. Sometimes you just cannot reach. Dr. Steve could add something on it.
I don't have any other additional comments, except that if you put PFO in place, you can often achieve laser that you couldn't achieve before that, simply because of the 1.8 specific gravity pushing the retina against the pigment epithelium.
And
Sangeet, any thoughts?
Yeah, because there's a question also, because what happens sometimes once you put PFO or you want to do fluid erection, you just cannot see a break also. You do not know what to do, where to laser. And you don't want to do excess laser in a papillomacular bundle or a nasal temporal side.
Absolutely. Yeah, I agree. So there's a question also, how about using tissue glue instead of ILM flap in cases of, these kind of staptum breaks? This is from Dr. Ajay Kapoor, Bhatinda.
I think Dr. Mudit has presented using
Yes. Mudit
tissue
Tyagi
glue,
is presented.
using tissue glue for retinal detachment. I think it's a very good idea. Otherwise, if it works, I've not tried it myself. No.
Yeah, but what I would add there is tissue glue gives you a temporary holding there till scar forms. Because I think if I remember correctly, he does laser, add tissue glue. Tissue glue holds on instead of having a tamponade probably for time being till the laser takes over for a peripheral break. But if you are not having created a atogenic inflammation, tissue glue will not help in this scenario.
Yeah, exactly. That's absolutely right. It's a
If
temporary.
it goes subretinally, it can have some toxicity at the macula. If it goes subretinally in the peripheral space, it does not have an issue. So,
yeah, right. Also about the same issue about the ICG. I mean, I understand that the visibility, it gives you greater visibility, but for the same reasons, because the RP and the choroid is so thin, these eyes will be more at a heightened susceptibility to toxicity. So I think that's one thing we have to kind of balance when you think of ICG. So fantastic talk. Thank you, Sangeet. Fantastic videos as always. So we'll now move on to another dynamic young surgeon from Jaipur, Dr. Vishal Agarwal, who's going to talk to us on GRTs, stacking GRTs. So Dr. Vishal, you're going to be presenting off your laptop and doing a narration.
I think I have a recorded video given to Sai. Sai, can you play my
Sai,
video?
yeah, that's fine. Sai, can you just play and Vishal will do the narration.
No, the narration is in it now. Thank you, VRSI, Shobit sir and Dr. Anand sir for having me here. Sai, can you play the video? It has my voice also.
Pars plana vitrectomy for giant retinal tears pose unique and complex challenges which, if unprepared for, can lead to suboptimal results. The first case is of a GRT with rolled edges, with the patient giving a history of only a week. Complete vitrectomy with trimming of the interior leaflets of the tear are done, as these sites are nidus for ischemic reproliferation. After the retina is sufficiently mobile, the posterior pole is stabilized with PFCL till the edge of the tear. As we can see that due to the adhesions, retina is unable to unfold with PFCL. We switch over to a forceps to unroll the retina. With a combination of forceps and trimming of the stiff edges, the traction is relieved and then the vitreous cavity is filled with PFCL beyond the GRT edges. Without the previous maneuvers, PFCL has a high chance of going into subretinal space. 360-degree indentation is done with peripheral shaving, and 3 to 4 rows of laser is applied to the edges of the GRT, taking care particularly to the GRT horns, which are adequately covered by laser. Fluid air exchange is performed in the last. It has to be slow, and thorough drying of the anterior retina has to be done till the PFCL bubble recedes beyond the posterior edge of the GRT. Once that is achieved, the residual PFCL can be aspirated from the posterior pole. Performing this step in haste can lead to slippage and seepage of subretinal fluid. This case demonstrates the anomalous peripheral anatomy found in many cases of giant retinal tears. After complete vitrectomy and PFCL injection, peripheral base shaving was performed. As you can see, we were also surprised to find multiple sieve-like breaks with a thin overlying vitreous sheet in areas of the attached retina. The breaks opened up during the base shaving. These findings are not uncommon in cases of GRT associated with congenital syndromes, and other eye should be meticulously screened and lasered if needed. Adequate removal of vitreous from these breaks and the GRT edges is important for successful anatomical closure in the post-operative period. This case is of a patient with Stickler syndrome having giant retinal tear and radial ribs. After vitrectomy, the crumpled retina is unfolded with a light pipe. The same can be done bimanually if a chandelier light source is used. Flattening of the retina with PFCL has to be done very carefully in these cases, as the radial tears are common sites where the heavy liquid can go into the subretinal space. The folded edges of the radial rib are ironed out with blunt instrument under the PFCL. Rest of the surgical maneuvers are similar to the previous cases. Direct PFCL silicone oil exchange is also used by many surgeons and is a personal preference. PFCL air exchange is a simple and controlled step giving an excellent wide angle view of the retina and is practically assistant free. Many cases of GRT present with hypotony and choroidal detachment. It's a good idea to inject saline to make the globe taut before entering the vitreous cavity with a 6 mm cannula. This case presented with a very large tear extending radially to the disc with a large gap between the leaflets. After vitrectomy, PFCL was injected at the posterior pole. As we can see, only one leaflet of that tear is covered under PFCL, whereas the other leaflet is tented up. This is the time to stop injecting PFCL and to relieve the traction on the other leaflet. So a thorough base excision was done in the area of the other leaflet to make it more mobile, and the edges of this leaflet were trimmed. After adequate traction removal, the vitreous cavity was again filled with PFCL with ironing out of the edges of the radial ribs. This was followed by 3 to 4 layers of endolaser and finally PFCL air exchange. Silicone oil is the preferred tamponade in such large tears with traction. Gas can also be used, especially in cases of superior GRT without traction. The common belief that giant retinal tear will have a pre-existing PVD is not always true, especially in high myopes and pediatric cases. As in this case, we can see a very thin cortical vitreous layer after vitrectomy and PFCL injection, which we attempted to peel under PFCL. The problem here is that the thick vitreous layer is easily separated, but the superior thin layer, which is communicating with the tear margins, falls back repeatedly due to the pressure of PFCL. So the heavy liquid was aspirated to peel the superior vitreous sheet. Repeated staining of the vitreous cavity was done with timestone acetonide, and finally the superior sheet was removed. This is difficult because after aspirating the PFCL, the retina becomes bullous, but with PFCL in situ, it is impossible to peel that sheet, and without that layer being removed, there is a very high chance of recurrence in the post-operative period. Most cases of GRT do not require encerclage, and even if it is required, a moderate band height has to be aimed, as a tight band can lead to slippage and subretinal PFCL related complications, like in this video. The band was released when PFCL was noted subretinally. The heavy liquid was then aspirated and retina settled. Fish egging due to turbulence of non-walled trocar is another undesired event which can lead to post-operative submacular PFCL bubbles. Low infusion pressure and using of walled cannula can circumvent this problem. So to conclude, the take-home points in the management of GRT are to do a complete vitrectomy, make the GRT edges vitreous free, slow filling of vitreous cavity with PFCL, adequate laser, slow and meticulous drawing of anterior retina under air, and finally choosing the appropriate tamponade. Thank you.
Terrific videos. Thank you, Vishal, for presenting that. Dr. Charles, your thoughts and comments?
Well, it was excellent surgery and excellent video, and I agree with the majority of points. A couple of things. It isn't just about injecting the PFO slowly, which is true. It's about where you inject. And I use the Med1 cannula because that allows you to not need a chandelier, and you've got a fluid egress port. And the tip should be first placed in the optic nerve cup. Then you know you're on the right side of the break. And then the tip should remain in contact with the bubble as it grows. So you're always following it up. That way you never ever get fish eggs. Fish eggs are from injecting above the bubble instead of injecting at the apex of the bubble. With respect to exchange for oil or exchange for silicone oil, the inverse is true. You must have the whatever you're using to remove fluid should be at the interface, which is meniscus shaped. So you've got air or oil on the top and PFO on the bottom, and this meniscus-shaped layer of subretinal fluid, residual infusion fluid, liquid vitreous, whatever, is at the apex. So at the peripheral part of that, you follow that down as you exchange, then you won't get slippage.
Can I ask one question? Because I believe we always learn from history. When I was training and Dr. Cyrus had just started practice, in that era, there was a lot of talk about management of the other eye in a GRT patient with even a belt buckle. Now, what is the current status of this? We are not doing that anymore, but is there any specific management for the other eye in a GRT patient?
I personally do not recommend to band in the other eye. These are often myopes. You don't want an encircling element around the eye for no reason. And patients can get a giant break posterior to the edge of the so-called new aura you made with laser or with a buckle. And so I'm unaware of data that proves it's a good idea. There was a recent paper that suggested it, but I felt like the study design was flawed. So I treat specific breaks with light laser, with a LIO, so I do vitrectomy in the first eye. While the patient's in the operating room and sedated a little bit, I just put the LIO on and treat specific breaks. I don't make rows. I don't treat the lattice. I simply treat specific breaks, and I try to make the laser very light.
Thank you. Excellent surgery, Dr. Vishal, and a great number of cases.
Thank you, sir.
Anand, can I make a few observations?
Yes, please go ahead. Sure.
But one was about the fish eggs. One is when you are injecting. The other thing is you have injected, but the infusion causes the fish eggs. So I think one of the steps we do take at that time is that on the constellation we switch off the compensation mode, and so that reduces the kind of jet of fluid which is coming in. And that we find that the phenomenon of fish eggs becomes much less with that, because sometimes even with a valve cannula, there is leakage and then some turbulence occurs and causes the fish eggs. The other thing was the edge of the giant tear, suppose a radial extension or even otherwise. One instrument we find very useful in unfurling the folded edge is a blunt tenno, a tenno where the diamond dust is kind of worn off. And I think that's it's because it doesn't have any suction, and that works pretty well to unroll the flap. And the third thing is that sometimes when injecting, even if you don't have an abjectly rolled edge, sometimes when you injected the fluid, you find at the end, injected the PFO, you find at the end of it that quite a significant amount of the flap is kind of folded over. And one way we try to avoid that is to use a bimanual technique at that time. And while you're injecting the PFO, you simultaneously keep a watch on the edge. And there's a similar thing like that blunt tenno. You see that the edge doesn't roll over while you are injecting. So that with that, you almost never get that sort of even a non-PVR edge folding over of the giant tear.
And you should always use valve cannulas to prevent fish eggs.
Yeah.
Dr. Cyrus, do you ever leave PFO in these eyes for a week or 10 days and in your GRTIs if as a temporary tamponade?
No,
That's what I always do. In every inferior, nasal, and temporal, I leave it for 2 weeks.
no, somehow we've never done that.
It
So,
works
but
great.
what is the rationale behind doing that? If you are sure about attaching the retina on table, why put a temporary tamponade for 2 weeks? Why subject the patient to a second surgery?
Well,
Because
many
if it's
surgeons make nicks at the firm rolled edge, and they feel that the PFO presses it with time. That's one logic. But I personally don't do that. I like to finish my surgery just like you did at one go.
Well, but if it's an inferior giant break, silicone oil doesn't work, and now the patients have to lay flat face down in the bed. And so if you put the PFO in, patients can literally go to work the next day, drive a car, fly on an airplane, go about their business. And so I get it that it's an additional procedure, but the additional procedure takes about 10 minutes to take the PFO out. And so for inferior, particularly children that won't position, inferior nasal and temporal, it works great to leave it in 2 weeks.
What about Densiron for these cases?
Densiron is bad stuff. It causes inflammation and glaucoma, and I've never used it.
Yeah, we have heard about the negatives of that, and also the cost of Densiron in Indian money would be more than the vitrectomy itself. So
And the hassle of taking it out.
Yeah,
and the hassle of taking it out.
it's a nightmare taking it out too. So one quick question last from Dr. Sangeet. We are actually over time. So Sangeet.
So Dr. Steve, sir, I'd just like to know, when you remove the PFCL after 2 weeks, do you add any other tamponade or just?
I often these are myopes, so I put air in because air acts as surface tension to seal the sclerotomy. So you just have less wound leaks with air. But I don't add anything else. I don't put oil in or anything because at 2 weeks you've got a strong choroidal retinal adherence.
Thank you. We'll move on next to Dr. Sarunan's talk.
Yeah.
Sai, can you play his video? And Sarunan will narrate.
Yeah, Thanks, Anand. I'd like to thank VRSI, Dr. Shobit sir and Anand for having me here today. So we'll just be seeing some techniques of tackling intraocular foreign bodies, especially the non-magnetic ones. Sai, can I?
Dr. Sarunan is a very gifted surgeon from Arvind Eye Care System and my colleague from Arvind Coimbatore.
Yeah, thanks. So to tackle with the myriad sizes and shapes in which the foreign body is present, we have multiple instruments and other ingenious techniques as well. So if it's a magnetic foreign body, dealing with them is quite straightforward. You just mobilize them, use the rare earth magnet, and then remove it. But when you have a non-magnetic foreign body, then that's the issue like you'll have to deal with. So here, this is technique we are using a suction of the vitreous cutter, or you can have even a hard tip cannula for this, which can be used to lift the foreign body towards the anterior segment, and then you can deal it either through the limbal section or through the sclerotomy itself. This is the case of foreign body with corneal tear as well as cataract. And you can see the suturing of the tear and the removal of the lens. And to keep the sclerotomies without sutures, we just mobilize the foreign body with the suction itself, and then with the handshake technique using a McPherson, we were able to remove the foreigner. So this is one more case where the suction technique using a blunt cannula is used, and this will help you to angle the foreign body in the right orientation to remove through a smaller sclerotomy. Because sometimes it's very difficult to orient them to remove it through a smaller sclerotomy. So you can see that that's being mobilized. The left hand has got the suction and the right hand has the engrasping forceps. So for other foreign bodies, you can use the lasso technique. In this case, I am using a 90 proline, which is inserted into an intravenous cannula to make a lasso. People have tried using the silk sutures with the syringe also. Here, this is the two 90 ends of the 90 proline, which is inserted to the steel part of the IV cannula, intravenous cannula. And you can adjust the loop and then plug it in to maintain that loop size. So you make a routine sclerotomy like you usually do and pass the lasso After releasing the vitreous around that, you just pass the lasso around the foreign body and then sort of hook it, and then you can remove it. So in case you don't have a rare earth magnet or you're dealing with a non-magnetic foreign body, this can be a way of dealing with it. So this is a case of a blast injury with multiple pieces of stone inside the eye. There were 2-3 smaller pieces which were used with just the suction using a blunt cannula. And you can see that is coming out the small pieces. And for the larger piece, we use the 90 proline lasso. So stones have a very rough surface and it's easier to hook them, unlike metallic foreign bodies. And then you can see the lasso being hooked on, and then I'm trying to drag it out. It was coming in the wrong orientation and to the wider end, and I was trying to pull it too hard and I ruptured the proline suture, as you can see here. So after that, then I used the suction to sort of reorient it, rotate it, and then using a routine conjunctival forceps was able to remove the store in foreign body. For extremely large foreign bodies, it's better to deal with using the prong forceps. You may have to use a Chandler slide because it's very difficult to orient them and hold them because the prong forceps got very less grip. So this the prong forceps. This is actually a large scleral tear there. I just extended it and then removed it, the phone, and then dealt. There's one more case of a child who had an injury with a pencil end. It broke off at the ciliary body, pars plana, and it was so slippery. I had very difficulty dealing with it and holding it. I dropped it multiple times. First, I tried the forceps, then I used the suction. But the main issue was holding with the McPherson forceps. So almost 10-12 times I dropped, and then finally I was able to reorient it towards the shorter end and then remove it. It's very slippery. So this is a handshake technique with the suction as well as the McPherson forceps. So this one more case where there's a bone arrow injury where the coconut leaf stem was stuck, which was sort of impacted between the sclera and the retina nasal to the disc. It was an infected eye with a lot of exudates in the vitreous. So I realized after clearing the vitreous, it's a very large foreign body. I was not able to assess this using ultrasound. And then it was totally tightly entangled with the sclera and the retina posteriorly. So very difficult to mobilize it. I had a little bit difficulty sort of releasing it from the retina. I had a small tear out there also, really extended when I was trying to release the posterior end because I was not able to release the scleral end. So I didn't want to drop because already the retina was inflamed. I didn't want to create additional tears. So I thought I'll fill the eye with silicone oil so that it will not move around. So I was doing the fluid air exchange and then filling the eye with silicone oil. And then I used the prong forceps to deal with this. So that's the oil going inside, and this is the prong forceps. Luckily, the lens was still clear. You can see I was trying to mobilize with the light pipe and holding it with the prong forceps. There's a very rough end, a little bit flat end, and it's not coming out easily. But you can see that even though I missed it, the foreign body is not falling down. So the additional risk of creating retinal injuries was prevented by using silicone oil in this case. So I just grasped with the prong forceps and then was able to remove it in the second attempt. That's about it. I just wanted to highlight various techniques I have tried out, and each person will have their own ingenious instruments as well as techniques to deal with such cases. I'd like to welcome comments from other panelists also. Thank you.
Thank you, Saravanan. I mean, there's a wide variety of cases.
Beautiful.
My only little comment was that in any case, for example, that pencil tip thing, I think just to make sure that it doesn't slip, once if you're taking it through the corneal scleral root section, then it's better to make a larger incision so that there should be no resistance to egress at that point. It's difficult to do it when you're taking out through a sclerotomy. You can't, there's a limit to which you can
Actually,
extend things. But here, I think,
the
that's
opening was larger, but somehow it was always slipping out. Even a small hit at the edge of the wound was making the foreign body fall. But it was very smooth and rounded. It is that type of pencil where the lead is hooked onto a plastic base.
Yeah, I understand.
Larger than the routine pencil.
It is a slippery customer. Yeah, I know. Also, Dr. Cyrus wants to know why couldn't you use a PFCL in the last case instead of silicone oil? Yeah.
No, I use oil in that. You can use PFCL, but PFCL is a little bit more watery and the foreign body tends to fall down. You can see in this case, even though I missed it, the foreign body never moved even a single millimeter. It was just floating in the oil. So I felt anyway, I have to fill the oil in this particular patient because of the large retinal injury nasal to the disc. So I thought oil will be more viscous and lesser movement compared to PFCL, which is more watery and fluid.
Excellent. Dr. Charles, your comments on this, and we're pretty much over time, but your comments, please.
Oh, very quickly. Excellent surgery. The most beautiful forceps we ever had were the Machmer Perel forceps that Grishopper made that were diamond coated. Unfortunately, they had a negative acting handle. You had to squeeze it to release it. So it was a bad handle, but the best tips. But they don't make them anymore. I wish we had that. The lasso technique and the section technique were very well described. I thought it was excellent work. I appreciate it.
Thank you, sir.
Thank you, sir. Any quick comments from
Sangeet?
Sangeet? Yes, Sangeet.
One thing, the instrument I personally use to these slippery bodies is the plug holding forceps. Once you put it in and catch the foreign body in the plug holding forceps, even a small rounded pellet-like thing will come out very nicely, so it won't slip.
Okay, sir.
Even the basket forceps also, I think, works well in case of larger.
Very small mouth. You cannot hold. Probably the claw forceps which
Manish Bapai.
Very good forceps.
Yeah. The only thing is we need to know the orientation when it opens up. Otherwise, sometimes we might hit the retina and cause.
No, you should open it inside the cavity, and it's great for irregular
foreign bodies.
Irregular foreign bodies. So terrific. Thank you very much. We have the other session speakers also waiting. It's been an absolutely amazing session. I'd like to thank Dr. Steve Charles for a wonderful lecture, taking time out so early in the morning on a Sunday. Thank you so much. You've always been there. More than anything, we appreciate your being a teacher to all of us and sharing your experiences. And I'd like to thank all the speakers for their excellent, video presentations. It's not been easy putting these together, and the panelists for their erudite comments and interactions and discussions. Thank you all so much. It's been wonderful. Thank you very much. Have a great day. Dr. Steve, I'll ask to hear a word from you.
Thank you very much.
Thank you, Anand. Thanks a lot.
Thank you.
Thank you, Anand, sir. Thank you.
Thank you, Anand, sir.
Thank you.
Thank you, Shobit, sir.
Yeah.
NSM, sir.
Right.
Bye.
Thank you.
Anand, you are there?
Anand,
Yeah, I'm here.
all the speakers, wonderful.
Anand, I think the other people, they're trying to enter.
Yeah.
Able
so
to
that's
enter.
what we need to.
Only at 7 o'clock or
Yeah,
that
they
can
will
get
be.
in?
They will be gated in right now. They will be gated in 6:45. Yeah, 6:45. Thank you again, everybody. Wonderful.
Okay.
Thanks. Wonderful. Beautiful.
Yeah, thank you so much. It's a nice session.
So Anand, we keep this link on for the next session.
Yeah, we keep this link on. Yeah.
Vishal, Sanjay. Thank you, Anand. Bye.
Thank you, Subhendu. Terrific. Bye.
Bye.
Yeah. So Sai, can we have? Can you allow the other faculty to come in?
Will do, Doctor.
Yeah. Also, Sai.
Yes, Doctor.
Can I just screen share and see if my presentation is coming through?
Please go ahead, Doctor.
Yeah, just 1 second. Let me just.
Just for your information, we are live.
Oh, okay.
Good evening, everyone.
Good evening, Mudit.
Morning, everyone.
Hi, good evening, everyone.
Good evening, Manisha.
Good evening, ma'am. Good evening, Dr. Chablani.
Yeah, Dr. Shablani is there.
Good morning, Tyagi.
Hi, Jay.
Hi. Hi,
Welcome,
Anita.
Welcome, Dr. Amod, sir. And good morning, Dr. Anita. Great to have you this early.
Hi.
Yeah.
Morning, sir.
Hello, hello. Hi, Anita. Good to see you after such a long time.
I know. There's everybody. I thought it was starting at 6 o'clock my time. I was so worried.
Oh.
Glad you called. Texted me Anand yesterday. Otherwise, I would have been really worked up.
Yeah. It's never too early for Anita, actually, to catch an academic session.
It's early. It's okay. I know I was a little worried that I was not able to get in. I was trying to change the background on my end, and I don't know what to do.
Okay. Oh, okay. So you need to just download that image.
Yeah. And I can do edit profile, hide self-view.
Yeah, from the virtual, you can select that image from virtual background, add image, and go on.
Uh-oh. That is something bad. Show self-view. How do I pull it there? I have it here. So I have the thing here. I'm not good at it. Choose virtual background. Okay.
Yeah. Then on the right, you'll find add image. And then choose. Once you do add image, you can choose it.
Doctors, I suggest you move to the breakout room because this session is going live.
Oh, okay.
So you can be on the breakout room. I've already assigned it to you. If you accept it, you'll be there.
Okay, can you assign it again? I think someone not heard.
Hello, can you take me to the breakout room too? Okay.
So Sai?
We are all seeing cases who've had, Covishield or Covaxin, and they are coming with a vascular occlusion, but they may have elevated homocysteine levels or other things or other predispositions. So we cannot very exactly say that these cases are because of COVID vaccination. What do you feel, sir?
Oh, I think, the papers that I have seen, they do have a strong temporal relationship. And when they start pouring from all across the world, you have something to think about. It's very easy to dismiss an idea, but the times are that we need to keep track. We need to compile these cases and finally make out, because something similar happened when the HIV epidemic was on, then they were seeing those funny opportunistic infections and stuff like that, and the lesions in the eye. And so I think we need to keep our options open. And let's see how it shows up in the third wave. So it will be interesting to see that, because now the physicians are wiser, much wiser than they were during the second wave.
So I think we're going to go live now in a few seconds. So Sai, let us know.
Yeah, we are live, doctor. You can go ahead.
Okay. So very warm welcome again to everybody to this second session of our VRSI's Independence Day webinar series. It's a pleasure to have a galaxy of wonderful retina specialists. It's my special pleasure to welcome Professor Amod Gupta to deliver our VRSI Legend speaker talk on iconic challenging cases, lessons learned over the years. We have an amazing array of panelists too. We have Dr. Muna Bende, who's the Deputy Director from Shankar Netralaya, Chennai. My co-moderator for this session will be Dr. Manisha Agarwal. We have Dr. Anita Agarwal from USA at very early in the morning from California, right over here. Thank you for joining us at this early hour. We have Dr. Adnan Tufel, who is somewhere in the United Kingdom, who's logged in and will be with us for some amount of time. He's from Moorfields and has been a great friend. Both Dr. Anita and Adnan have been great friends of VRSI, and it's great to have them here. We have Dr. Mahesh Shanmugam, who's a stalwart of the RedNet scenario, and he's been a great, again, supporter of VRSI activities, and is somebody who's wonderful for case discussions. And before we go on further, we also have our own who got away, one of us who got away to Pittsburgh, Pennsylvania. Jay Chablani, and you welcome in the morning. It's a little later in the morning for you. Welcome again. So without further ado, may I request Dr. Amod Gupta sir to begin his talk on iconic cases, lessons learned over the years. Dr.
Anand, I would request
Sai, kindly play the video.
But it's not audible.
Diabetic macular edema has always been those cases who have had massive hard exudates in the macula along with macular edema. When you treat them with laser photocoagulation or with anti-VEGF or the DEXA implants, there's a subfoveal migration of these hard exudates, and that leads to subfoveal fibrosis and irreversible visual damage. More than 20 years ago, this patient came to us, was dyslipidemic, had diabetes for almost 14 years, massive deposition of hard exit in the macula, and a baseline visual acuity of just counting finger vision. Around that time, statins were not indicated for patients with diabetes. They were still undergoing trials. But we put this patient on atorvastatin, and you can see within 6 weeks, the hard exudates are started melting away. We did the focal laser photocoagulation at this point of time, and we see within 18 weeks, most of the hard exudates have resolved. And by 18 months, he had recovered 6/12 vision. Now we know that statins have pleiotropic effects and possess anti-thrombotic, anti-inflammatory, antioxidative effects. Patients on simvastatin have been found to have lower intravitreal levels of VEGF, fibroblastic growth factor, as well as angiopoietin-2. It's always also been known that statins lower the VEGF levels not only in the coronary artery plaques, but in the retina as well. We published the results of our control trial, one of the first such trial ever carried out, and we got published in the AGO for 2004. In its category, it's one of the highly cited, most cited paper. And I'd like to show you this patient in colored pictures. And this is where before at presentation with 660 visual acuity, dyslipidemia, and after statin use, the hard exudates are melting away. We do a laser photocoagulation and you find sequential. Within 8 months, the visual acuity has improved from 660 to 6.9. The hard exudates and macular edema have gone away. So the lesson we learned that all patients with diabetes, especially those with diabetic retinopathy and diabetic macular edema, must receive the statins rather than, some of the retinal surgeons have been trying these years to do subretinal surgery to wash away or remove these hard exudates. This is irrespective of whether you are using laser photocoagulation, anti-VEGF agents, whichever anti-VEGF agent, as well as the DEXA or steroid implants. Now, my third patient is a 39-year-old male. He's a type 1 diabetic for the last 12 years, and he was referred to us with diabetic retinopathy. You can see a number of cotton wool spots, a lot of hemorrhages and microisms are visible on fluorescent angiography, many of which these microisms are peaking. When we investigated this patient, we found that he had hemoglobin of just about 4.7 grams percent. He was investigated very extensively to find out the cause of anemia, and it turned out that he had iron deficiency anemia, and he was required 2 blood transfusions as well as supplement with iron and folic acid and multivite. Within 3 months, his hemoglobin improved to 12.6 grams. And by this time, when we reviewed this patient, all the microisms and edema has disappeared. A few dots remained at about 3 months, and his vision had improved to 6.6 from 20/40. We followed this patient up to 16 months, and you can see there's hardly any trace of diabetic retinopathy in this particular patient. Even on fluorescent angiography, there's hardly any microism visible. The lesson we learned from this patient was that all diabetic patients must be evaluated, especially those who have diabetic macular edema, and there is no emergency treatment required for a proliferative retinopathy. They must be looked for modifiable or reversible parameters like hemoglobin A1C, blood pressure, dyslipidemia. Renal functions are very well known to all of you, but those factors which induce hypoxia and thereby lead to overexpression of VEGF specifically need to be looked into, like anemia, history of smoking, and obstructive sleep apnea. We described a long time back a new clinical entity of tubercular surface like choroiditis, which is now recognized all over the world and treated as tubercular pathology. We have published a number of papers on this disease and extensively cited. Now, I'd like to share one of these patients. He's a young 21 years old who presented to us multifocal choroiditis, the lesion is expanding. She's already on 80 milligram prednisolone. She had what we mean skin test, which was highly positive. Because of the fear that her phobia might get involved, we withhold anti-TB drugs for a while. By about 1 month, the lesions have expanded. By about 3 months, now the lesions have further expanded, and we decide to start her on anti-TB drugs at this point of time. Yet, 2 months later, we find the lesions have expanded furthermore, and vision is actually going down, and we offer her a diagnostic, which is surgery, which was subjected under air for obtaining vitreous samples undiluted. And now what we look at the labs, the gene expert test for MTB was positive, and rifampicin resistance was reported. Multiplex polymerase chain reaction was positive, the RPB gene sequencing was positive, and it showed that there was a resistance at codon 526. The line probe assay also showed the presence of, so 3 tests showed that this eye harbored MTB genome, which was multi-drug resistant. So she was duly put on a treatment for a drug-resistant TB. This is what to show you the gene sequencing, and you can see here CAC to TAC is a mutation, point mutation, which is a very common site for drug resistance in MTB. Now, following surgery and the use of MDR treatment, you can see the resolution of all these choroiditis lesions. The visual acuity improved. We followed this patient for about 2 years, and she had no recurrence, and the vision remained 6/6. We realized from this patient, and subsequently we published a number of papers on drug-resistant MTB genome presence in patients of tubercular uveitis, and in about 5% of these patients, we might have a drug-resistant MDR genome. That we need to keep in mind in patients specifically who do not respond to conventional 4-drug anti-TB therapy. My 5th patient is a 35-year-old, again patient of serpiginous like choroiditis, and he had been treated very extensively in the past in several institutes of the country. He had come from Madhya Pradesh, and he was in a depressed state of mind. He had received prednisolone beginning at 80 milligram. He had received methyl prednisolone. He was already receiving methotrexate, and his visual acuity was going down progressively. He had significant inflammation in the vitreous cavity. Now, when we did the fluorescein angiogram, you can see the extensive choroiditis patches which are expanding and causing loss of vision. And now you realize why this patient was in a depressed state of mind. We asked him that we like to do, from our previous experience, we like to do diagnostic vitreous surgery, to which he agreed. And again, under air, we did the obtained the vitreous samples. The PCR of viruses were negative. The gene expert for TB was negative, but multiplex PCR for MTB was positive, but it showed the presence of rifampicin sensitive MTB genome in the vitreous cavity of this patient. But subsequent to the vitreous surgery, we found that within 3-4 days, his visual acuity improved from 360 to 636, and within a month, it had improved to 618, and the lesions had practically resolved. You can see these are very active choroiditis lesions at the edge of the scar. These had healed even before we could institute a 4-drug anti-TB drugs. Of course, we put him on anti-TB drugs, and you can see the follow-up at about 4 months. He had recovered 6/6 vision. The patient was very happy at this point of time. And we followed this patient for about a year, and he remained recurrence-free. We subsequently published a large series of patients, and we looked at the response of microincisional vitreous surgery in these patients, and we found that the need for corticosteroids substantially decreased, and in fact, in almost half the eyes, we could stop the use of corticosteroids. The visual acuity started improving from day 1 following surgery, and kept on increasing progressively up to 12 months. I think similar kind of results have been shown by Dr. Soumya Basu in patients of serpiginous like choroiditis due to tuberculosis. My last patient was one of the major challenges which I faced, was a 31 years old male. He presented to me with 3 months progressively decreasing vision, with a lot of inflammation in the vitreous cavity. Looked like a toxoplasma causing neuroretinitis, and we investigated him. All the tests were negative except for tuberculin skin test, which was positive at 15 millimeter. Based on our clinical judgment, we started him on 2-drug oral therapy for toxoplasmosis. About 10 days later, we discovered that this patient had a number of intraretinal hemorrhages. We did an angiogram and we found that on fluorescein angiogram, this lesion was highly vascular, giving rise to a suspicion that this probably represented neuroretinitis caused by cat scratch disease, which again happens to be, angiomatous lesion that are seen in vascular cat scratch disease. We gave this patient intravitreal bevacizumab and looked at the response. There was some response, but not complete response in this patient. 5 weeks after presentation, he has not responded to toxoplasma therapy, so we stopped that. He had actually TB skin test positive, so we started him on anti-TB drugs based on a clinical suspicion. We subjected this patient to carcinoma vitreous surgery for cytology for negative for malignant cells or AFB. The cultures, both for aerobic and anaerobic organisms, were sterile. The PCR for MTB was negative. We also subjected this patient to monthly injections of intravitreal bevacizumab. 10 weeks after the initial presentation and diagnostic vitreous surgery, you can see the site of the original granuloma here, the scars. He started developing epiretinal membrane. And a few months later, we subjected this patient to epiretinal membrane surgery for 6 months after presentation. And all along, this patient has been receiving oral corticosteroids. His anti-TB drugs were stopped. And he developed another granulomatous lesion below the optic disc. We hiked up his corticosteroids, and when he presented next, about a year and 9 months later, after the initial presentation, the lesion had stabilized, and we stopped his corticosteroid therapy at this point of time, and we thought he was going to do very well. Not knowing what he has. Patient returned 4 years and 3 months later, and now he has another granuloma in the periphery with a peripheral retinal detachment. The diagnosis was so obvious at this point of time. So in summary, what I have shown you are a few of my iconic cases where we had some of those lessons that we learned. And the major lesson we learned was statins are a very useful adjunct, no matter what treatment you choose for your patient with diabetic macular edema, the anti-VEGF agents, the DEXA implants, or even focal laser photocoagulation. We also learned that we must look for any modifiable or reversible risk factors in diabetic retinopathy and diabetic macular edema, especially look for hypoxia-inducing factors like anemia, smoking, and obstructive sleep apnea. We also found that rarely TB, serpiginous like choroiditis lesions, may in fact be caused by MDR, MTV presence in the vitreous genome presence in the vitreous cavity of these patients, and we have to be on the lookout for MDR or TB in these patients who do not respond to their conventional therapy. We also found that, and we reported our extensive series on microincisional vitreous surgery is a very safe and effective procedure, and a view which is now shared by Dr. Soumya Basu, also who has published a large series of doing the surgery for resolution of lesions in TB, serpiginous like choroiditis. And finally, when you look at these migrating granulomas, remember, Toxocara is a prime suspect saliva migraines. Thank you very much, my friends, and Dr. Anand again, for letting me share some of my iconic cases with you all. Thank you. Thank you very much.
Thank you so much, Dr. Amod, sir. It's always a pleasure to listen to you, Dr. Amod, as we always the teacher of teachers. And I mean, he set the tone for this fabulous session, aptly titled "The Phantoms of the Retina." You know, where we're focusing on atypical diseases and their manifestations. So, could I ask Dr. Anita on your impressions and your inputs on this? Yeah, on anything we would like to comment on from an international perspective.
On the 6 cases, my God, each one of them was an lesson teaching case. I do remember the 2 cases, the first ones, the diabetics and the anemic. I thought you had another lady with anemia that you published in one of the British journals, BMJ.
This
just
is the
pure
patient
anemia with retinopathy that got better after treating the anemia.
Yeah.
So I remember those cases, and
this is the case which we published 2005 in VJO.
Correct.
And subsequently, there are a number of reports now, people treating anemia, they're looking for anemia. In fact, when we talk about statins and we talk about anemia, you know, there were no guidelines like by the American Academy or, you know, the other academies. They were not even talking about these things. But I was surprised to see last year that all these factors have come back, and they are charging now the ophthalmologists to look at the systemic condition of the diabetic patients, and they are being told to you know, mind those parameters which can be reversed. You know,
I'll tell you, the US system has you know, everything is so specialized. I think that's where the patients are lost, because the ophthalmologists are looking at the retina, the internist, everybody writes letters to each other, but I think there's so many letters that are automatically generated that people forget to look at them, or they just passes through their system and they don't look, unless you actually pick up the phone and call the doctor, or you really stress and write a big paragraph on the top. Most of these electronic records, you can just hit create a letter and it'll automatically do a letter, and it's just automatic. So most internists may not even get it, or they don't look at it. So I think there's a big disconnect, whereas in institutes like PGI, you know, you have the internists right in that building, so you can send them off and you can call them or you can walk them over. So there's a little bit of a disadvantage in the US system with that. And I think in that the patients are lost during all this transit. And, you know, for me, because of my Indian education, I will sometimes call the doctor, or I'll really write a letter, I'll keep on bugging them with my letters and write a big paragraph on the top. And I think that is important. And for us as ophthalmologists, we see so much inside the eye that we can help these patients for their systemic disease. And I still can't forget what I learned in PGI. You know, when the patients had renal insufficiency and they had diabetes, they had this kind of breath and smell around them that you could know that their kidneys were bad, and you could take them over to the renal guys. And I saw that as a first-year resident here in the VA. And I told them, your kidney, you need to go see the nephrologist. VA system is better because everything is in one building. You can take them over. So the next time the patient came, he asked the second-year resident who had asked me to see the patient, how does she know my kidneys weren't good? And so my second-year resident asked me that question. So I told him, I said, you know, I could smell the uremic breath. And then the patient was upset because I said I could smell it. Of course, I was an Indian girl at that time. I'd just come from India, and I didn't realize all the social things about how I said it. And I just said, oh, because I could kind of smell the uremic smell. Anyway, so I think a lot of times we are at an advantage sometimes of being able to diagnose certain things that the other people might have missed. And I know the US system, they do labs and everything, but somehow, somewhere in the midst of that, it's lost. And I think all of us have to be careful and sort of be on the vigil for looking for these unusual features that will help us.
So can I draw in Dr. Adnan on, you know, the perspective, your perspective of how tuberculosis is presenting, and are you seeing in this day and age atypical presentations in the eye? Are we not hearing you, Adnan?
Can you hear me now?
Yeah, perfect. Yeah.
So I'm, as you can see, I'm properly dressed for this meeting.
Oh, perfect. Amazing.
So but the standards are not quite so high from others. But anyway, just to say, so we see quite a lot of diverse manifestations of TB. There's a very large Indian community in Northwest London, where I do a day a week at Northwick Park, which is a very large Gujarati community. We also have a large African community, and there is HIV. So we do see a very diverse manifestation of TB, not as much as you guys, and we do still get caught out by it. So it's still a mimicker, and we still pretty much test everyone as a differential now in London for TB. Just to go back to the wonderful case on statins, which was still really the RCT from, I think that you did, is still really the definitive paper in this area. I think how statins work is still unclear. A colleague of mine, Arun Hingarani, who I work closely with, who's a cardiovascular physician, did a Mendelian randomization study on, because people thought statins could work as an anti-inflammatory mechanism in heart disease, and it doesn't. So it doesn't work through a CRP mechanism. So it's not really an anti-inflammatory. So we don't fully understand why it's so effective over and above its lipid lowering effect. We have been fortunate, we've come full circle. When I first started at Moorfields, my mentor, Peter Hamilton, had a brilliant diabetic physician in the clinic in the eye hospital next to him. That went away, and we got rid of that. And in the last 4 years, we brought back in a diabetic nurse specialist who sits in our clinic and actually can do HbA1cs on the spot and do look up their labs. We now have integrated labs with the primary care physician, and actually manage and alter their treatment within the clinic. And often when the patient's diagnosed and they see the patients see their own eye with lipid about to dump on their fovea, they're far more motivated than otherwise. So we've almost come full circle now. We reintegrated a diabetic nurse specialist into our clinics at Moorfields to really address that and to put patients on statins where appropriate. My memory from that original paper, however, was only patients with high lipids were put on statins in that RCT. Is that correct? Have I or would you put all patients on statins with lots of lipid on the macula? What's the views of the panel?
The common saying is that those people who have diabetes are in a similar situation as a non-diabetic patient with one coronary artery attack or one MI. So since all patients who have MI have to have lipids, all their life, so is the diabetics who even didn't have any MI as yet. But all these patients, even if their lipid profile is good and they show hard exudates in the macula, they need to be on statins, and these days, if I may say, there's interest in these hard exudates because they're seeing these on OCT. They're seeing these hyper-reflective foci or hyper-reflective dots. And they have been wondering, why is these dots, causing poor visual outcome in our patients? And now we know that these hyper-reflective foci, and there are very recent papers which have come, which, and adaptive optics and other technologies they've used, they say, well, these are the same hard exudates which are moving, posteriorly, and you may find them around the fluid cavities, ring around that, and these are the ones which are phagocytosed, or they may be free lipids, or they may be present in the microglia and stuff like that. So there is I think the interest back again into these lipid particles in the retina. And people are reporting and doing now subretinal surgery. Come on, why can't you give 4 weeks or 6 weeks of statins, and we are not talking of 40 milligram or 80 milligram of statin, we are talking of 10 to 20 milligram of statins. And, why subject that fellow to surgery to remove or wash off that hard exudates? Because once they move under the fovea, there's almost 50% chance that they will develop subfoveal fibrosis. and there's nothing that you can do about it. Even if you remove, like some of the surgeons are showing, removal of, coronary vascular membranes, fibrosis, once you remove from the fovea, takes away the RPE and the photoreceptors. I mean, there's never going to have central vision again. And I've just shown you those couple of examples, in fact, from a series that we reported. And I think even now, 20 years later, almost 20 years to the work that we did, this paper remains very relevant even today.
So I completely agree. It's still the most influential paper in the area, and really influences my practice. But my memory was, in your original paper, you only put patients on statins who had high lipid.
Sure. That's
and
right.
What would be wonderful if somebody repeated your original study in patients with exudate to the macula with and without high lipids, because I'm actually very persuaded by your cases.
Yeah.
Dr. Amod, just another question. I think in PJ now, in the last few years, vascularized tuberculomas, there's a propensity to treat with anti-VEGF along with ATT. Right. I just wanted your comment on that, and I'd like to draw in others from the panel, Dr. Mudit, Dr. Mahesh Shanmugam.
Anand, I wanted to show that patient.
Yeah, I was thinking you would actually.
Yeah, but because of the restrictions of time, I didn't show that patient. Now that was years ago we showed, and we now have about 7 or 8 years follow-up on that lady we first treated. And this is coming from what we call now host-directed therapies for tuberculosis. Tuberculosis is basically a hypoxic granuloma. And people have shown already in the lungs and in extrapulmonary locations, including the eye in animal models, except this wonderful work from Nursing Rao's lab, that these hypoxic granulomas are they have overexpression of VEGF. So it makes sense to treat these granulomas, and which we have seen and which we have shown, they're highly vascular granulomas, unlike the sarcoid granulomas, which are not as vascular as the TB granulomas. And if you use anti-VEGF agents like bevacizumab or Lucentis, these tend to regress much faster. They will not progress, they will not leak, the fluid will kind of dry up, subretinal fluid will go away, and it's a very useful adjunct. In fact, this particular patient, which we reported in the BGO case reports long time back, and subsequently we've had follow-up on that patient for another 4 or 5 years, and every 2 or 3 years she gets a recurrence of the fluid. A shallow fluid develops under the fovea, and she knows now that this is the time to get another shot of Lucentis. So she gets 1 or 2 shots of Lucentis and remains all right for the next couple of years. So these granulomas somehow remain alive all the life. I mean, it's been such a long follow-up for this lady, 8 years with us. God knows how many years this is going to continue. It's like all the TB granulomas, which lie quiescent all your life, and suddenly it becomes active. So it's something similar happening perhaps in the eye. So it makes a lot of sense. And now there are a lot of papers, a lot of thoughts on this. In fact, the guy in Australia was very keen on, these host-directed therapies. And he says anti-TB drug probably is not the way to go, but, use these kind of, even systemic therapy, so he's a kind of a rather disease modeler or experimental guy. So, so far nobody has treated systemic anti-VEGF therapy for tuberculosis.
So Jay, I think you have a question. Jay has a question on foveal migration. Jay, would you like to articulate that?
Yeah, if only if the time permits. Sir, we obviously, like everybody said, that we have learned so much from your contribution, especially about the hard exudates. Because I was doing a couple of studies using steroids and looking at the hard exudates. So I was wondering that after your statins, which I have personally used for some of my patients, so how was the edema responded, as well as did you face that the migration of hard exudates were towards the fovea, or they actually just disappeared completely?
It's towards the fovea. It's interesting because this was a controlled study. It was not a very big study. It was a controlled study. And in the group with the statins which we treated, and as Rafal said, we had dyslipidemic patients, because that was the time when statins were not indicated as yet in diabetics. In fact, they were contraindicated because no trial had been done on a diabetic population till that point of time. So this was after getting our ethical committee approval, we could manage to convince some of these patients to have statins versus no statins. So in patients who did not receive statins, 30% of those patients had migration in the towards the subfoveal migration. They tend to migrate towards, because they're moving towards the outer retina all the time, and they're tending to go under the neurosensory retina. They are going to lie over the RPE. They are going to, cause proliferation of the RPE there and cause subfoveal fibrosis. That is the mechanism. Okay.
Did you
all move towards that?
Did you see the similar foveal migration while they were undergoing resolution in the statin group as well?
No, there was none. That was the most impressive part. In fact, there was no difference in the visual acuity. It was a very short-term study. It was just about 24 weeks study, 6 weeks therapy, and then we were following them up for 24 weeks. So they did this, get that point of time. The standard of therapy was focal laser photocoagulation. We had not even heard of anti-VEGF therapies in 2001. So I like to show all my patients before anti-VEGF era, because we could obtain similar kind of results, in that era also. And now, of course, we can obtain similar kind of results with anti-VEGF agents. But even with anti-VEGF agents, the fluid goes away very quickly, and the lipids tend to precipitate. Because these are in soluble form, they tend to precipitate. The moment their concentration increases in the extra, what we call extravascular space, so they tend to migrate towards the fovea. Eventually they'll go away. Yeah, eventually they'll go away.
Thank you, sir. It has been a very integrating discussion. Can I ask my co-moderator, Dr. Manisha, to get the next set of speakers on? Manisha, over to you.
Thank you so much, Anand, and good evening to everyone. So continuing with the session on atypical presentations of retinal diseases, I now invite Dr. Dhananjay Shukla, who is the Director of Vitreoretina Services at Ratan Jyoti Netralaya, Gwalior. With his vast experience, he would be speaking to us on atypical presentations of diabetic retinopathy. Over to you, Dhananjay.
Very good evening to all, and Vande Mataram to all my Indian colleagues. I would start straight away. So I would start these words of Richard Feynman. Am I audible to everybody?
Yeah, just the volume needs to be a little higher.
And if you could do the slideshow, please.
Yeah, put it on the slideshow, please.
Yeah, so why I start with these words of Richard Feynman, because what we call atypical today might become typical in a few years' time. So there is a worldwide increase in diabetes, and even in India, there are close to 80 million diabetics who also live longer since the discovery of insulin, just like ROP children. Like we have experienced from COVID-19, the unusual cases keep on coming as we see more and more of the same disease. So if recognition is the first step in treatment, let's dig in. I and Anand did this study, this actually review long time back in current opinion. And we are in a position of the 6 blind men who feel the elephant in a different way and tell different things about the same thing. So what makes diabetic retinopathy atypical? It's maybe inherent variability of the disease itself, which we don't know about, or there may be coexisting systemic diseases, as Dr. Amod was just explaining to us, the ocular disease affecting diabetic retinopathy and some other stuff. Let's look at the inherent variability. The most important thing is diabetic disc edema. The other is featureless retina, peripheral lesions in diabetic retinopathy, which are supposed to be a posterior pole disease, an unusual course of diabetic retinopathy, and the tractional component in diabetic papillopathy. So what is diabetic papillopathy? It is basically a transient bilateral disc edema in a young diabetic patient with good vision and a minimal diabetic retinopathy. And typically he's a type 1 diabetic. This is supposed to be an extension of retinopathy onto the optic nerve head. And it generally resolves on its own without any sequelae. So why should we know about it? We should know about it because it has to be differentiated from more dangerous conditions like raised intracranial hypertension with papilledema, from malignant hypertension, new vessels on the disc, and also optic nerve drusen. So it was a clear-cut condition. Still, people start describing it in old patients as well as unilaterally. Now we should know that whether a patient is diabetic or not, the commonest cause of unilateral disc edema in a middle-aged patient is non-arthritic ischemic optic neuropathy, which typically causes visual loss, field defects, RAPD, classic angiographic defects, and also on follow-up there's a disc pallor. But still, there is so much overlap in the spectrum of these two diseases. When unilateral in an old patient, the Dr. Here exclaimed in exasperation, there is nothing like diabetic papillopathy. Well, I have to disagree with the great man, because we have some classic cases where you can see a diabetic papillopathy, which is very distinct from AION, resolving asymptomatically and without any sequelae with classic telangiectated vessels. So there is an entity like that. Another entity which intrigues me a lot is featureless retina. Now, I've been reading about this for the last 30 years on all the editions of Ryan, but it has never merited more than a single paragraph. What does it look like? It is basically a PDR masquerading as a mild NPDR. So why? Because the preceding severe NPDR changes somehow get disappeared or glossed over. So what do you see? You see an atrophic retina with wide thread-like arterioles, and you should look for these cases when you have PDR in one eye and a falsely mild NPDR kind of appearance in the fellow eye. If you do angiography in these eyes, in the most of the cases, you can see an extensive capillary closure and also presence of new vessels. For example, we had this case with the fellow eye classic PDR. It looks like a mild NPDR. You can see some sheathing of the vessels here on the nasal side and superiorly. And when we did angiography, we found that there was a high-risk PDR with massive NVD. So whenever we see a sheath vessel, we jump to the diagnosis of vasculitis. And we do not pause to think whether the sheath vessel is an artery or a vein, because if it is an arteriole, then you are more likely to be dealing with a case of featureless retina or diabetic retinopathy rather than a retinal vasculitis. For example, in this case, on angiography, you can see there's neither leakage nor sheathing or staining of the vessel. On the other hand, there's occlusion of that arteriole. Everything which is asymmetric may not be featureless retina. For example, this eye is also a fellow eye of a patient with classic PDR with vitreous hemorrhage. When we did angiography, we didn't find any new vessels. But when we looked slightly in the periphery, we found peripheral new vessels as well as capillary dropout areas. And mind you, this is a normal 50-degree fundus photography and angiography. So peripheral diabetic retinopathy, which occurs by definition outside the 7 standard ETDRS fields, has been described ages back by the Japanese authors in about 2 to 3% of cases. When we got our hands on, especially Adnan Tufail here and Dr. Rajiv Raman, they published recently in Griffith's archives that it is seen in about 30% of cases, more than 30% of cases of diabetic retinopathy. And Silva and al. Have shown that it increases the risk of worsening 3 to 5 times. So peripheral examination is required and mandatory in assessing diabetic retinopathy progression. And is there some specific field? Yes. Rajiv Raman and colleagues have told us that you should look harder in the temporal periphery, especially the supratemporal quadrant. So does it look like the gold standard ETDRS grading is not good enough? Some people think so, and we may have a new classification on a wide, ultra-wide field imaging. So there's another 6 blind man movement for me. Diabetic retinopathy is no longer a posterior fundus disease. Now we look at the unusual course of diabetic retinopathy. We have all experienced that in some cases that diabetic retinopathy has a florid course. It rushes very faster, and in spite of treatment, the patients have poor outcome. On the other hand, some cases regress on their own, and it is extremely rare to the extent that just 3 diabetic women constituted an original article in AJO 1996, where Dr. Don Guess was also a co-author. And they showed for the first time that there's not only a spontaneous capillary barrier healing, but also reperfusion of CNP areas and actually reversal of the grades of diabetic retinopathy. This was then. What is now? Now is the common knowledge after RISE and RIGHT studies and VIVID and VISTA studies that reversal of diabetic retinopathy says does occur along with resolution of macular edema with anti-VEGF treatment. Another 6 blind man movement for me. So then there are curio pieces, and I'm most interested in tractional diabetic papillopathy. I saw a case where vitreoretinal traction probably contributed to the visual loss more than the macular tractional edema. So we had this patient who had a vision of 6/9 in the right eye and looked like a high-risk PDR. On angiography, we found there were no NVDs, only telangiectasia. We did an OCT and found a macular edema, but it was more prominent on the nasal side, and there was some traction on the disc. So I was confused and I did not let this patient have any injection. On the follow-up after a month, the patient lost vision and I was aghast. The vision was 636. But lo and behold, the macula was actually flattened and it was the disc which was showing increased traction. So I explained to the patient that this might be a case of tractional diabetic papillopathy. We operated, was simple surgery, just inducing a PVD, and the patient improved perfectly to 6/6. Then you can have the cases of systemic diseases which mostly aggravate diabetic retinopathy. Now, hypertension, hyperlipidemia, and carotid ocular disease are the most common of them. Hypertension is so common that Tony Adamus commented that we should not ask whether the diabetic patient is hypertensive. We should ask if he's not hypertensive. I have seen personally a lot of undiagnosed hypertensive patients. For example, this young man who had malignant hypertension but was not aware of it. And simply by treating his hypertension, we could bring down the macular detachment without any injections and also the visual acuity. Then there is a case of lipemic retinopathy, which occurs in about 2% of diabetics with the bilateral course-like response. Dr. Gupta has elegantly elaborated about it, that statins help so beautifully in these cases, even when the systemic lipids are normal. What about ocular conditions? Some of them which are ocular degenerations like high myopia, glaucoma, optic atrophy, retinitis pigmentosa, or any condition which causes extensive choroidal scarring, for example, multifocal choroiditis or geographic GSPC. All of them cause a metabolic slowdown and therefore slow down the progression of diabetic retinopathy. And they cause much confusion when they are unilateral. A similar thing can happen when a patient has PVD because it removes the scaffold for new vessel growth. This is an uncontrolled diabetic who got a tractional detachment in one eye, but was just saved by the dumb luck of having high myopia in the other eye, which prevented the progression of diabetic retinopathy. There are other diseases which alter the picture of diabetic retinopathy. I am reminded of J always, macular telangiectasia and radiation retinopathy. Now, this is a case which amuses me because as a patient, diabetes is very common in patients with MACTEL2. Now, if you look at the angiography, the most prominent leakage is actually not diabetic leakage. It is the wispy leakage characteristic of MACTEL2 and should never be treated. If you do the angiography, OCT, it confirms that there is a case of foveal atrophy and not leakage. In fact, laser will actually harm the patient. So when you have asymmetric diabetic retinopathy, what one should look for? First of all, when do we call it asymmetric? We call it asymmetric when one eye has severe NPDR or PDR and the other eye has very mild changes and they are stable for about 2 years. Second thing, we should remember that diabetic retinopathy per se is extremely rarely asymmetric. More commonly, we may have a case of peripheral diabetic retinopathy, which have been shown to be in about a third of cases, a case of featureless retina, or a unilateral ocular pathology, or ipsilateral carotid insufficiency. So the knowledge of unusual has led us to the first evidence of neurodegeneration in the diabetic vascular disease. Now we know that it is also a neurodegeneration because of the first shown asymmetry in retinitis pigmentosa. It has improved our diagnostic sensitivity, for example, in featureless retina and peripheral diabetic retinopathy by modifying medical treatment as in lipid diabetic retinopathy or surgical treatment as in tractional diabetic retinopathy, avoiding unnecessary investigation of treatment, for example, in diabetic papillopathy and MACTEL, or aggressive treatment as in florid DR. Most importantly, it was the first observation of asymmetric diabetic retinopathy by Beetham and Aiello because of unilateral choroidal scarring, which actually led to the gold standard treatment of panretinal photocoagulation. Thank you very much.
Thank you, Dr. Shukla. That was again a beautiful exposition of the variety and the spectrum that diabetic retinopathy can put us through. So may I invite comments from Dr. Amod Gupta first, and then Dr. Mahesh.
I have it's a very nice presentation, Ranjay. I have just a small point because very recently, a lot of people are talking about looking at the data from, various trials on anti-VEGF therapies and looking at the diabetic retinopathy severity scores or severity scale. They're showing two-step reduction and all that. Now, please bear in mind that this reduction in severity score is in terms of only the secondary effects. Say macular edema, and the stuff like that. There is no reversal of the diabetic retinopathy pathology. The primary pathology stays. The primary pathology here is the ischemia, the capillary non-perfusion areas. Nobody in the world till date, to my mind, has shown that any amount of anti-VEGF therapy reverses the retinal ischemia or reduces the capillary non-perfusion. The day we have achieved that, we would have achieved, a treatment for diabetic retinopathy. Till that point of time, we are just reversing some of the secondary effects like vascular incompetency, leakage, hard exudates, cotton wool spots and stuff like that. We are not targeting the primary pathology. So we have to keep in mind, these are not long-term solutions. The second point of the optic disc pallor, when you brought in the subject of non-arthritic ischemic optic neuropathy, I would also suggest when you're evaluating a patient with optic disc pallor, please do a confrontation visual field. Last year I had shown a patient whom I had the privilege of following for more than 35 years. Okay, of a patient with non-granulomatous uveitis. And in the process, he had become diabetic. Somebody was looking at him and saying, you have developed optic atrophy because of diabetes. All along, the guy was harboring a craniopharyngioma. And by the time the patient become blind, they kept on harping the theme of optic disc pallor due to diabetes. So we should not be focused on the local pathologies all the time. Just show him the fingers. If the guy had shown him the finger and temporal field or look for the altitudinal field effects, things would have been clearer. So I think we should not lose sense of, we shouldn't be carried away by, like Anita said, we have to have a holistic approach. We are primarily physicians first, then ophthalmologists. Let's not be confined only to the optic nerve head or to the retina in our lives. We need to look at the patient as a whole. We need to do that. Thank you.
So quick comment from Dr. Mahesh Shanmugam, sir, on the whole debate about diabetic disc edemas, AION versus diabetic papillopathy. What is your take on that?
Like that was a nice presentation by Dr. Dhananjay. I agree with Dr. Dhananjay. Like, it's not that diabetic papillopathy doesn't exist, but then you need to rule out the traction part of it. And it's usually the PDR with the NVD which presents subsequently as the traction part of it. So if you see the NVD with a little bit of fibrous tissue which is pulling up the disc, then I would consider vitrectomy. But then BEP studies have also been done in these patients to show that there is a progression, in which case we can do a vitrectomy. So that's one. Like, if I can make a couple of more comments, I would agree with Dr. Professor Amod about the not able to reverse the diabetic retinopathy, because I used to believe that we are able to reverse the diabetic retinopathy, but the recent studies have shown that despite the anti-VEGF causing regression of PDR, the visual field effects seem to be increasing. It's as good as the chronic PRP. So that's the latest study which has shown. So we don't seem to be having an effect of reversing the diabetic retinopathy, and there is still so much more to learn about diabetic retinopathy, despite the fact that we are treating the anti-VEGF agents. And one other comment about the silent retinopathy, one of the reasons why we think it's silent is these patients don't seem to have much of macular edema. So it's not that like hemorrhages and hard exudates are not there. So we tend to think that these patients do not have diabetic retinopathy, wherein they seem to have proliferative retinopathy in the periphery.
Thank you. Thank you.
May I make a comment?
Yeah, please, Anita.
A quick one.
Yeah,
I think 4 things that I want to kind of say is that
please.
if you see diabetic retinopathy that's not kind of responding, look at their feet. They may have pedal edema and fluid retention. So you want to look at their feet and you want to kind of take their shoes off. Second is sleep apnea, especially patients who are kind of obese and diabetic. You have to think about sleep apnea and see if that's playing a role. Third is medications, glitazones. You know, sometimes they have wrong glitazones. So you do everything, you do anti-VEGF, you do focal laser, it's not going away. Take a look at their meds, and if they're on glitazone, try to see if you can take them off of glitazone. So, and renal failure, you know, patients, somehow they'll tell, oh, my doctor did my labs and everything's okay, but they may have renal insufficiency that's sort of been not really paid attention to. So those are 4 things that I always look for in patients that don't respond as I would expect them to respond.
Anita is still smelling patients' breaths.
It's good that we're doing this remotely. So thank you. That was wonderful. May I now invite, it's my pleasure to invite Dr. Muna Bende, a teacher to many of us. She has great insights into macular degeneration. It's my pleasure to invite Dr. Muna Bende, Deputy Director of Retina Service at Shankar Nethralaya, Chennai, to give her talk on atypical presentations of AMD and PCV.
Can you see my slides and hear me?
Yes, madam. Please go ahead.
Yeah, thank you to VRSI and Anand for inviting me. And it was an honor to share the stage with one of the greatest teachers, Dr. Amod Gupta. I will be sharing a few cases on atypical presentations of AMD and PCV. These are just typical pictures and the classic definitions of the 2 conditions, and I'm going to share a few atypical cases with you today. Taking off from where Dhananjay stopped, this is an elderly gentleman with a typical diabetic retinopathy. You see the hard exudates of the macula, the hemorrhages. He has an atrophic scar in the macula of the left eye. Both eyes had temporal disc pallor. This was the fluorescein angiogram, which showed an ill-defined stain at the macula in the right eye and staining of the scar in the left eye. Along with pan-retinal photocoagulation, he underwent an injection of ranibizumab in the right eye. And a month later, you see a reduction in hard exudates and hemorrhages. He felt better, though his vision remained at 6, 9, and 6. On the left, you see his OCT showing a good anatomical result. A lot of the edema has gone away. And you see this regular elevation of the retinal pigment epithelium just adjacent to the fovea. I called him back in a month's time, and he reported with a sudden drop of vision of about 660 in less than a month. And the significant difference I could see on the OCT was an increase in the area of RP undulations under the fovea and some shrink. The left eye was the same. We did an OCT angiogram at this time, which showed there was an underlying neovascular membrane at the fovea. Because of the unexplained drop from 6.9 to 6.60, we evaluated him for possible optic nerve pathology since he had a temporal pallor to start with that was negative. And systemic features, as Anita mentioned, always look at systemic features. They were significantly deranged. We sent him back to the physician. He came back in a month's time with the diabetes under better control. And you see an increase in size of the neovascular membrane under the fovea. He's just had a second injection of ranibizumab. I'm waiting for him to come back. This was the OCT angiogram of the left eye. Now, the combination of neovascular AMD and diabetic retinopathy is not well studied, but there has been the occasional report, and they show that vision is stabilized and there may be a stable or improved diabetic retinopathy stage throughout follow-up. So I would name this case as when the obvious overshadows the occult, and also makes a case for the role of OCT angiography in diabetic macular edema. My next case is a gentleman I first saw in 2019 when he presented with a large scar in the macula in the right eye and some macular fluid and drusen in the macula in the left eye. His vision was 6.6 and 6 in the left eye. This was his fluorescein angiogram and ICG, which showed features suggestive of a small occult choroidal neovascular membrane, dilated choroidal vessels on the ICG angiogram. OCT was typical for an active type 1 CNV. So over the next 6 years, he received injection bevacizumab on a PRN basis, maintaining 6, and 6 throughout. 6 years later, he presented for a routine checkup, and I found that he had developed a nasal juxtapapillary choroidal neovascular membrane and a similar one in the other eye as well. Now, this was his OCT, which shows there was barely any fluid at the macula, but there was a type 2 CNVM adjacent to the optic disc in the left eye. This was his fluorescein angiogram and ICG at presentation, and this was the fluorescein angiogram in 2015 showing the CNVM adjacent to the disc and an ill-defined mottling at the macula. But what clinched the diagnosis was the swept source OCT, which showed the grossly thickened peripapillary choroid and the very large dilated choroidal vessels. And if you look at this picture, you see that the thickening is more on the nasal side of the macula than the temporal. And over the next few years, he received multiple injections of anti-VEGF, maintained a vision of 6, and 6, but you see this membrane continued to grow and encircle the optic disc. And this was the swept source OCT angiogram, which looks almost as if the CNVM is strangulating the optic disc. The large choroidal vessels are significantly dilated in the optic disc area. And what was also curious was that there was this original subfoveal type 1 CNV, which remained distinctive from the peripapillary CNV. Now, peripapillary pachychoroid syndrome is recently described, but what we know is that it does not come with choroidal neovascular membrane. So this case is a little different, though there has been an occasional case report. So I would name this case as when you think all is well in the macula, always remember to look around the optic disc as well. And it also tells us that CNV can occur in peripapillary pachychoroid. My third case is an elderly gentleman with avascular pigment epithelial detachments in both eyes. Over a 3-year period, you see an alteration in the contour of the pigment epithelium, detachment with some surface irregularity, and occasional cystoid spaces that appeared and disappeared. And this happened in both eyes. In 2017, when I saw him, I saw these little patches of atrophy on the surface of the pigment epithelial detachment. You see them well on FAF imaging as dark spots. The OCT shows that the pigment epithelial detachment has a fairly dense configuration. There are some cystoid spaces above the PED, and the typical oval hyperfluorescent lesions, which are well defined, seen at the surface of the pigment epithelial detachment and the margin. This was an area of pigment epithelial atrophy. There was no evidence of choroidal neovascular membrane. And in the left eye, the PED had flattened, leaving behind atrophic changes. Now, over the next 1 year, the pigment epithelium detachment flattened, as you can see here, and what we thought was a good result. But if you look carefully at the edge of the PED, there is something new developing. There has been an irregular elevation of the retinal pigment epithelium with some involvement of the inner choroidal layers, and this occurred exactly at the margin of the original pigment epithelial detachment. The fluorescein angiogram and ICG at this time showed an increase in the areas of RPE loss compared to 2017. But just look at this small spot here, which showed up like a small ink blot leak, which corresponded to this area of RPE irregularity. And we did an OCT angiogram, which showed new vessels in this area. We advised him a very close follow-up because there was no fluid here. He was traveling abroad and subsequently underwent 3 injections of bevacizumab while he was abroad for an increasing size of the neovascular membrane. When I saw him in February 2019, he was maintaining a vision of 6, 9, and 6 in this eye. You see the increase in size of the pigment epithelial, fibrovascular pigment epithelial detachment, significant increase in size of the choroidal neovascular membrane. Now, retinal pigment epithelial apertures are a recently described entity. They are round discontinuities either at the apex or the base of an avascular PED. And curiously, there is no change. The PED appears as smooth, unlike a retinal pigment epithelial tear. These are known to either increase in size or develop new lesions, and most often are unassociated with choroidal neovascular membranes. So I would call this case as when you thought it was the end when the PED flattened and you thought that was it, this patient developed a new vessel at the edge of the PED, which was unusual. And this case also taught the role of assessing individual lesion components to pick out the lesion that was more likely to cause a problem. My next case is a 34-year-old hypothyroid lady who presented with blurred vision in the right eye due to this submacular hemorrhage. If you look at her fundus, very distinctive multiple pigment epithelial detachments scattered all over the posterior pole with some drusen-like lesions temporal to the macula. This was the fluorescein angiogram she brought with her, showing hypofluorescence in the late stages corresponding to the PEDs. And this was what clinched the diagnosis, the ICG angiogram, which apart from showing blocked fluorescence, the area of the pigment epithelial detachment, and an active leak subfoveally, it showed these classic donut-shaped lesions, which are very typical of large colloid drusen. And this is the crossover OCT in the side showing that there was a hemorrhagic notched pigment epithelial detachment. You see the OCT of the left eye showing multiple typical pigment epithelial detachments of large colloid drusen. After one injection of ranibizumab, the submacular hemorrhage disappeared, the lesion had flattened somewhat, and now we were able to pick up the vascular network under the fovea. And this was the patient after just one injection at 3 months, her vision was 6 uncorrected. Choroidal neovascularization and geographic atrophy can occur in patients with large colloid drusen. However, these occur usually later in life. And abnormal quiescent neovascularization in these eyes has also been described, and more recently, a case of polypoidal choroidal vasculopathy. So when the patient profile does not fit, a young patient who looks like she has AMD, there are 3 things you need to think of: cuticular drusen, large colloidal drusen, or autosomal dominant radial drusen. And this is my last case, a gentleman whom I have been following since the year 2007 for possible CSR in the left eye. In 2011, when I did an OCT, I found this little excavation of the choroid at the fovea with 2 hyperreflective structures within it. We observed the gentleman on a regular basis, and over a period of time, he developed a peaked pigment epithelial detachment along with subretinal fluid at the fovea and as a PCV lesion that was just bordering the area of choroidal excavation. He underwent multiple sittings of anti-VEGF injections as well as photodynamic therapy. In 2015, you see the swept source OCT shows the large choroidal vessels typical of pachychoroid adjacent to the area of choroidal excavation and the polypoidal lesion at the base. The ICG confirms dilated choroidal vessels as well as the polypoidal choroidal vasculopathy lesion. And over the next few years, and he continues to have injection aflibercept on a PRN basis and maintains a vision of 6/6 in the side. This is his OCT angiogram showing the branching vascular network. And we now know that focal choroidal excavation is not just a curiosity, it can be associated both with PCV and choroidal neovascular membranes. So something we think or thought was a random imaging curiosity landed up with a lesion that needed to be treated and continues to be treated almost 9 years down the line. So this is the summary of my cases, and I look forward to comments from the panel. Thank you so much for your patient listening.
Thank you so much, ma'am. And I think each and every case that you showed had a very important learning, and it's always a pleasure to see how beautifully you image and follow up your cases. I'll just invite some quick comments from our panelists, starting with Dr. Shanmugam, please.
Thank you, Dr. Munna, for the wonderful cases. Like each of them, we could learn something or other. I had a question. The RP aperture, all of them seem to show some kind of a leak. So how would you differentiate it from underlying CNVM, and why I see that like you've not treated them even if there was some leakage on the angiogram. So what stopped you from treating?
Yeah, that picture described to be very typical of an RP aperture with the intense staining on the surface and some fuzziness at the borders. But we did an OCTA, we did not find any neovascular membrane there. That's why we decided not to treat. And at that time, probably I was not even aware that such a thing existed. It was just a curiosity. I think the first reports came just around that time.
Dr. Anita, any comment from you?
You're muted, Dr. Anita.
Yeah, the one with the PED and getting CNVM at the edge of the PED, often, PED occurs at the edge of an occult CNV. So it's possible that the CNV was there for a long time and was invisible because there was no blood flow through them. And, when the olden days when we didn't have anything else but focal laser, we'd go and treat this if they showed a leak, and then you'd get a rip because they would be anchored at that edge. So question is, are all our imaging modalities able to pick up occult CNVs? Even OCTA won't pick it up unless there's flow through the CNVs. And, sometimes these CNVs have been sitting there for a long time with no flow. They're more like cords rather than tubes. And Gas showed that in many of his histopath slides of AMD. So it's something that we have to be aware of, and you treat it only if you see activity, and definitely watch the edges of the PED. That's where they're sitting around. And colloid drusen, it's kind of like a larger version of cuticular drusen. And so I think now that we have imaging, we kind of splitting everything into little kind of compartments, and we don't know where the overlap is. But I think the one thing to remember is, even if you call it colloid drusen, that it can have features that can go with the other ones. So we just have to keep an open mind about kind of splitting hairs about all these diseases with imaging. And I think all the imaging gurus are trying to rename and kind of split everything into multiple different sub-entities, which I don't know if that helps us, or I don't think it helps us that much in managing. And I remember when we didn't have OCTs and we only knew clinical findings, or you used an FA, cuticular drusen, Don Gas taught us he thought it was excrescences of the pigment epithelium's basement membrane. And he thought that's how it was different from exudative drusen. I still have histology of his eyes. But now we know that lots of patients who have cuticular drusen, the young patients, their 30s, 40s, or 50s, down the road, they can develop exudative drusen, AMD drusen. So there's probably, the same eyes can develop something else down the road. And when you go back and look at all these cuticular drusen patients in older age group, they have some features that are cuticular and some are exudative. So I think I used to be so kind of compartmentalized about what he taught me. And now I realize that there's a lot of overlap and other diseases can occur. So we keep an open mind. And I guess the most important thing is to look for evidence of CNV in all these diseases. Choroidal excavation, pachychoroid, again, pachychoroid, posterior pachychoroid is really CSR that is more localized to the back. And you can rename them into all sorts of compartments, but the key thing is to look for unusual features and kind of catch them and treat them.
I have a question to Anita and Dr. Muna. These drusen, how are they different from the ones associated with glomerulonephritis or the renal disease? Are they looking different?
What did you say? What is the last word?
The renal disease, the ones associated with renal disease. Yes.
With the type 2, the complement disease. See, that's so rare. It used to be called MPGN type 2. Now we call it dense deposit disease or complement activated disease. And everything's getting renamed and sort of organized. I think they all have a type of cuticular drusen where things are occurring at the basement membrane of the pigment epithelium. Overall, these diseases cause changes to the pigment epithelium, blood outer retinal barrier breakdown, and they're nidus for CNVM because the Brooks membrane breaks. So I think if you really have the renal disease, then it is MPGN type 2 or the dense deposit disease. And if you don't have that, the same features can be seen in other things, say also in North Carolina macular dystrophy. You can see it in patients with Malatia levantinase. They're all changes occurring at the pigment epithelium, but some are very specific. Of course, Malatia levantinase is very specific. They have really kind of very sort of excrescences coming out of the pigment epithelium's basement membrane. And they're all types of cuticular drusen, which is what Don Gas had called. And if you go back and look at his original paper on a cuticular drusen, the same eye histology that he described in light microscopy was taken by the Iowa guys. He sent it to Iowa and they studied the constituents in that material. And the material that's in the cuticular drusen histologically is the same as what you get in age-related drusen. So I think it's the same material accumulates, but they accumulate in slightly different fashions in different diseases. And eventually they all cause break in Brooks membrane and cause CNVMs. So I think down the road, we'll probably know a little bit more details about these things. And
yeah, I think there was a recent report on the different kind of drusen, and I think everything else has an association. Like malacia has a definite genetic defect, and the cuticular drusen can be associated with MPGN. This is one of which comes under the unknown category, where they look more like serous pigment epithelial detachments multiple when you look at it. So this comes under sort of a doubtful inheritance. I think nobody's established it, and that's where it's split up.
And it's very, I mean, if you look at them, they're symmetric sometimes. And you look at somebody's eyes, they have the temporal macula, it's not in the macula, it's outside the macula, and they're very symmetric. So there's something that we'll learn down the road. And some of them are in the macula, some outside the macula. Most of them are younger patients if you see them when they're early on. And I think you can name them all sorts of names by the appearance, but who knows what they'll all be eventually.
So I think since we are running late, I'll just take quick last two comments, one from Dr. Dhananjay and then to Dr. Jay.
Yeah, my comment is to Muna, just to inform you that this RP aperture, which you read about in retina, I and Anand described it about a decade ago in Ostley retina actually, and that paper went unnoticed. Just for information. Thank you.
I have cited your paper. I just wanted to make two quick comments. One was the AMD patient with diabetic retinopathy. I'm just wondering that the visual acuity which deteriorated, that could have been because of the intraretinal fluid accumulation. So maybe combining with Ozurdex and continuing the anti-VEGF therapy may be another alternative. The other comment I had was about the interesting case of PPS with CNV. As you beautifully showed that the thickened choroid and the type 2 component of CNV, and we saw that the CNV actually grew in spite of continuous anti-VEGF therapy. So I was wondering that maybe offering a combination with PDT may be a good option in these cases, because one of our recent paper in AGO, we showed with Javid Saraf, we showed that PDT is a very good option for PPS associated fluid. So maybe we could think of PDT in PPS associated CNV as well.
Dr. Muna, any last words?
No. I think we are.
You're eager to say something on PDT.
No, only if you have PDT, right?
Yeah,
you don't have PDT.
That goes unsaid. That need not be mentioned.
So now I'll invite Dr. Anand for his talk on atypical presentations of CSCR and exudative maculopathies. Dr. Anand needs no introduction. He heads the retina services at Arvind Eye Hospital, Chennai, and also is the chairperson of the scientific committee of VRSI. Over to you, Anand.
Thank you, Manisha. It's a pleasure to be part of this session. So I'll be talking to you about atypical presentations of CSCR and exudative maculopathies. Are my slides visible, Manisha? Am I audible?
Yeah, very much, Anand.
Thank you. So going on, before we delve into the atypical, let's a quick look at the typical. This is how we usually see CSCRs with the classic ink blot leaks. Not very often we find CSCRs with the more dramatic smokestack leaks. And of the atypical presentations, obviously the teardrop ones are the ones we see quite commonly with the inferior atrophic gravitational tract seen more vividly on the fluorescein angiogram. Leak distortions are also seen, as you can be seen here. And this is very often because of subretinal fibrin tracking under the surface of the retina to that leaking PD beneath. Now, bullous CSRs often present with RP rips, and sometimes they can be massive. And no presentation of mine is actually complete without the reference to this iconic case, where we have an atypical CSR with a multi-pronged complex RPA rib with massive subretinal fibrin and inferior bullous detachment. And on the angiogram, you see that ripped out area with the exposed sclera underneath showing up, as one must say, a white lizard. And on the progressive angiograms, you find that the tail of the lizard is catching fire and the extrafoveal leaks are lighting up. The autofluorescence shows up the lizard in its negative. It's a dark lizard. The OCT shows the at different levels. You see the vacuolated fibrin here, the RP rip there, and the minimal foveal detachment at this point accounting for the good acuity. So the TTT was done in this patient, could afford PDT, and there was a pretty good result at the end of 6 months and seen more dramatically on the montages. Bullous CSRs, when chronic, can rarely present with neovascularization of the iris, and something which is not really recognized and something we reported. So this was a case who presented with the CSCR with the inferior bullous detachment. You can see paramacularly and peripapillarly, there's a lot of fibrin. And inferiorly, you find neovascularization, you find the subretinal precipitates mimicking choroidal infiltrates, and somebody can mistake one for the other. And in another location, you find a neovascularization. Again, these subretinal precipitates lining the vessels, simulating vasculitis. The angiographic leaks were seen temporally, and inferiorly you find the massive neovascular fronts there with significant amount of capillary non-perfusion. OCT showed a skytic macular edema with minimal detachment. The standout feature was the neovascularization of the iris, and we treated the patient again with 2 TTT spots. Patient could afford PDT. Next day, intravitreal avastin was put in, and 4 months post-treatment, you see a flat macula. The NBI was wiped out, and a complete regression of the CSCR and the fibrin, as well as angiographic regression. This was something we published in IA a long time back. Now, diabetic retinopathy, Dr. Shukla has elegantly showed us so many permutations and the presentations can often present with a chronic CSR also, and makes for a complex presentation. So this was a middle-aged gentleman who came in with severe NPDR and with serous macular detachment, a PED, and a mildly fibrinous subretinal fluid. Got a shot of avastin first up, and 4 weeks later, the SRF went away, but the fibrin remained and actually intensified, and the drop in equity. And down the line, 6 weeks later, that intensified further, the fibrin, and on the angiogram, you can see the fibrin distorted CSCR leaks. We counseled the patient for PDT. Patient opted for conservative management, largely on account of the fairly decent vision at that point of time. But then 8 weeks later, there's a massive accumulation of fibrin, and the patient accepted and underwent PDT, and with remarkable resolution and a gain of equity. So this was the clinical sequence and profile of the patient from baseline through 4, 6, 8 weeks when the fibrin increased, and post PDT when it resolved. Now, this is a recent favorite of mine, a case which showcases what we believe that CSCR and uveal effusion syndrome are at opposite ends or at different course points of the pachychoroid spectrum. Now, our patient was a 56-year-old male with painless progressive diminution of vision over the last 3 months, diabetic hypertensive cardiac, left eye acuity 612, bilateral choroidal folds. I'd like to direct your attention to that. Serous macular detachment mild with some drusenoid changes, hard exudates. OCT showed pachychoroid in both eyes, and the foveal detachment and the peripapillary skytic edema. Now, angiogram showed hypopermeable foci, pachyvessels on ICG, no classic CSCR leaks, staining of drusen on the angiogram and choroidal folds, and therefore we thought it was open shut case of pachychoroid with left eye CSR. Photodynamic therapy was done, and 1 month later, post PDT, gratifying results, CSR resolved, equity came back to 6.6. But 3 months later, to our consternation, we found recurrent subretinal fluid in the fovea and around the disc edema, and all signs of incipient uveal effusion syndrome. Equity slid down to 6.9, and a florid disc leak was to be seen, a very confused, congested choroid. Axial lengths were 25 millimeters and a little more. Uveitic profile otherwise was normal, and diagnosis was revised to left eye uveal effusion syndrome. We treated this patient with parenteral dexamethasone, and in no small part on the basis of what Shields had reported, success in 104 eyes of uveal effusion with steroids. Unfortunately, over the subsequent weeks, equity decreased. There was progression of uveal effusion syndrome, increase of subretinal fluids, disc edema. You can see that massively increased and turgid choroid. Exudative detachments came in, choroidal detachments came in, so much so that there was imminent angle closure and mandated YAG PI. You can see the inferior detachment there that drove us to advise subscleral sclerectomy. Unfortunately, the patient opted to wait and was lost to follow-up for 3 months. But when the patient came 3 months later, to our delight, there was spontaneous resolution of uveal effusion syndrome. You can see the complete resolution of the SRF and the RD, leopard spot retinopathy, and post-cataract surgery acuity improved to 612 and has been stable for the last 1 year, and we've written this up. So now tying the CSCR, pachychoroid, and uveal effusion syndrome together, work from Spade and the Japanese group led by Matsumoto tells us that in pachychoroid, the discrete segmental nature of the vortex vein system is lost. The anastomosis happens. These anastomotic vessels, some might call it pachyvessels, trespass the sacrosanct watershed. When these anastomoses are seen in the macula, you get CSC or pachychoroid neovasculopathy. When it's around the optic nerve head, you might get peripapillary pachychoroid syndrome. Now, this increased sturgescence, hydrostatic pressure, and hyperpermeability kicks up the uveal effusion syndrome pathology. And therefore, CSR might very well, in this setting, be a harbinger for uveal effusion syndrome. And vortex vein, as described by these papers, implicated in pachychoroid, we know that vortex vein decompression was one of the therapies suggested earlier for uveal effusion syndrome. And you see in our case, you can actually see those pachychoroid vessels, the anastomotic channels sweeping up into the macula, and therefore that CSR was an atypical one and perhaps a harbinger of this uveal effusion syndrome. So the unique features of this case was CSR morphing with uveal effusion syndrome, features of pachychoroid and spontaneous resolution of the uveal effusion syndrome, prompting our pathogenetic postulate that UES may lie at the extreme end of the pachychoroid spectrum, and that in a case of pachychoroid, when you see vortex vein anastomosis, short axial and choroidal folds, that should raise red flags and suggest that if there is this decompensation of pachychoroid, it may lead to incipient CSCR and then a full-blown uveal effusion syndrome. So CSR can also mimic other diseases, like it can mimic choroiditis. Very commonly, this is happens, and the subretinal people can distort the leak, as seen here, and sometimes people can mistake it for CNVMs. The leaks will show up. What looks like a case of IJT is actually a case of inferior of a CSR with the inferior gravitational tract, and seen on the angiogram too. Diseases can masquerade as CSR2, as this young female who had reduced vision over 3 days, acuity 618 parts, multifocal serous detachment seen in the right eye. Angiogram shows these point leaks, CSR-like point leaks showing up. But what is the real giveaway here is that disproportionate amount of subretinal fluid, which you see on the later angiograms, on the fluorescein is pooling, and more importantly on the ICGS, a very large disproportionate area of hypocyanescence, which is totally disproportionate for those little leaks out there. OCT further firms it up with the septate fibrinous material and the tent-shaped PEDs, which is not typical of CSCR. And ultrasound fixes, kind of confirms it with the subtenon fluid. It's a case of posterior scleritis, uveitic workup was normal, and proof of the pudding lies in the pudding, where meltdown with the steroids or almost rapid loss, regain of vision, and the melting of the inflammatory material completely. Another masquerader is this particular kind of case where you have what looks like CSR with subretinal fibrin or a differential of an AMD. The angiogram shows no leaks. OCT in the right eye shows catechism with a bit of atrophy. The CSR at different levels, so serous fluid, and this is why one could confuse it with CSCR. And you see that flocules are at level C below, but it is the autofluorescence which shows this to be a case of adult onset macular from dystrophy with the streaking lipofuscin latent material. Another case which looks like an inferior gravitating teardrop tract of CSR is actually dome-shaped maculopathy, and you see the diffuse leaks there, and this went away with TTT. Another case which looks to the casual observer like a CSCR with a diffuse leak is actually a focal choroidal excavation, and this went away with PDT. So in summary, central serous choroidal retinopathy is a common macular disorder, has protein presentations, and recognizing these varied manifestations and distinguishing them from other serous and exudative maculopathies is often the most challenging step in the management. Thank you. I think we lost Manisha a little, so may I invite comments from Dr. Anita first?
Couple of things. One was, the posterior pachychoroid. disease. I had one patient in 2008 and 2009 that I had this guy after cataract surgery, and I took him to the OR thinking I'll decompress as posteriorly as possible and take out to see if I can kind of thin his sclera, because there was no leak, so I couldn't really do PDT. And there was one time there was a little leak near the disc. I did PDT, the fluid went away and came back within 3 to 4 months. Anyway, I went and looked at his sclera, and it was nothing like uveal effusion sclera. So it's not thick. It's not, I don't think the problem is in the sclera. I think it's in the choroid and the vortex vein and drainage. So I'm not sure scleral decompression with making scleral windows is a good option. Maybe there are selected cases that we can eventually find that have maybe localized thick sclera that we can measure before we go and take them to the OR, because I did this long ago, maybe 12, 13 years ago, and really didn't.
Yeah, so actually with uveal effusion syndrome, there are 3 categories. Yoyama said that. So the issue is not with the nanophthalmic short eye. There it works. There you have to pay the alternate drainage channel. The issue is with type 3 uveal effusion syndrome, where you have normal axial length and normal sclera, which you have to do an MRI or histopathology to make that out. But our case was most probably a type 2 uveal effusion syndrome, where success has been partially reported with sclerectomy. But in the Shields, a large sequence of 104 eyes where they showed in type 3, where sclerectomy does not help. And that came on the basis of just 2 cases in that Yoyama series. That is where Shields group has reported success. So
I know. I think adding the steroids probably worsen the CSR component.
That is my experience. My experience with this. So we took a shot because this patient was very high risk, was not willing for surgery at all. So we took a shot, but as you saw, it did worsen. And then fortunately, thank God, it improved.
Yeah. So the bottom line is most of these posterior pachychora or the chronic CSR ones don't really respond. Definitely get worse with steroids and they don't really respond with scleral windows. So that I would keep outside of the thing. Absolutely. And I think the one that you had towards the end, the focal choroid excavation CSR, I think they're both the same disease in that person, in the sense the focal choroid excavation is probably a result of a CSR. I don't think they're 2 different entities. So I think you treated the CSR component and things fluid went away, and the focal choroid excavation remained. When you're doing TTT, I'm interested in knowing what parameters you use. We've never really done TTT in any of these CSR eyes. I don't know if others I don't know if Jay has any experience about it, but it's interesting to know because looks like India doesn't have the laser or doesn't have Visudyne, right, for PDT?
Absolutely. Yeah, we don't. So this was a long time back. I mean, when PDT was very much around, just that these patients couldn't afford it, and that's why we used to do a huge amount of TTX, especially for extrafoveal pathologies, and we saw that in that ripped area. So we tried to get in. We tried to determine the threshold power. And then we go about 30% less than that, and that seems to help. So
and you used just regular
A10. Yeah, just dry laser. Yeah. So if I could bring in Jay on this, Jay is somebody who's our resident CSR expert. So Jay, I know you're itching to weigh in.
I really don't think that we have much time, but phenomenal cases as usual. But I think particularly the case with uveal effusion syndrome and CSR, as Anita correctly pointed out, that not all cases have thick sclera. But I think there is definitely some evidence which is coming across where they have shown from Japan that where they have shown anterior sclera has been found to be thick. But honestly, how much can we trust that how thickened the sclera is anteriorly and similarly it is thickened in the posterior pole as well. But the paper which talks about the venous overload choroidopathy, which just came in PRER, which clearly is trying to redefine all the diseases in and around choroid and leading to different presentation. So I think we all have to learn to look at the venous congestion primarily by using the white field indocyanine green.
Yeah.
I think we should move on.
Yeah, sure. So can I now invite our next speaker, Dr. Vinod Kumar from AIMS, of Professor at AIMS, who always has a huge bag of cases to talk about. Yeah.
Thank you so much, Dr. Anand. Is my screen visible and am I audible?
Yes, please.
Okay, so I'll be talking about atypical manifestations of retinal dystrophies and MACTEL. And I think it's a huge topic because most of the dystrophies present in atypical manner. So I'll try to share a few of my cases. So let's talk about first scenario. We all know about this particular condition, Mizuo-Nakamura phenomena. Typically, when it is associated with normal fundus and preserved vision, we label it as Oguchi's disease, which is a kind of CSNB. Mizuo is nothing but a golden yellow reflex, which disappears after dark adaptation, which is usually prolonged. So if you dark adapt for 2 to 3 hours, the reflex tends to go away. Now, we came across this young male who was a high myope, who presented to us with decrease of vision and nyctalopia since childhood. He could not read any plates on the color vision, and best corrected was 2200 in both the eyes. Now, when I first had a look at the fundus of the patient, I was pretty sure I was dealing with the Mizuo phenomena. But when I look at the macula, I thought, oh no, why this bullseye lesion is there? And which was very well seen on autofluorescence. And this dark reflex, actually we made metallic reflex, we actually made the patient undergo dark adaptation, and this reflex decreased in the both eyes, more in the right eye. Coincidentally, this reflex is better seen on red-free photographs, and OCT of this patient showed selective loss of outer layers at the macula only. This patient underwent full field electroretinogram and showed extinguished rod as well as the cone responses. But interestingly, after prolonged dark adaptation, the rod responses did recover a bit. So we diagnosed this patient as cone rod dystrophy with Mizuo phenomena. And what we learned from this case, when we went into the literature, that Mizuo phenomena is not seen exclusively in Oguchi's disease, but can also be seen in X-linked cone dystrophy and X-linked retinoschisis. Unfortunately, we couldn't get the genetics done in our patient, but over a period of time with wide field imaging, I came to know that while in Oguchi's disease, the Mizuo reflex tends to be panretinal, that is distributed all over the retina. In X-linked retinoschisis, this reflex is seen only in the peripheral retina. While in cases of road cone dystrophy, this reflex is distributed in and around the posterior pole. So to summarize the scenario one, a reflex similar to Mizuo can be seen in other conditions, and clinical picture and distribution of the reflex, however, tend to be different. Coming to scenario two, we came across this 24-year-old male who presented to us with decrease of vision in his right eye for 1 year. The best corrected was 2400 in the right eye and 2030 in the left eye. Now, the right eye showed a full thickness macular hole and a yellow deposit peeping through it, with the surrounding retinal detachment, which was limited to the posterior pole. While in the left eye, we had a typical presentation of the vitelli-eruptive stage of the best vitelliform dystrophy. We went ahead with the ERG, which showed depressed responses, EOG, sorry, which showed this depressed responses in both the eyes, and we diagnosed this patient as best vitelliform dystrophy. This patient underwent surgery with the inverted ILM flap. The patient did well and improved to 26C after the surgery. Now, a month later, we came across a similar patient where, again, we had a macular hole RD in one eye, and other eye had a vitelli-eruptive stage of best vitelliform dystrophy. This patient, again, underwent surgery and did well, and we reported our series. And in fact, the similar success had never been reported previously. Interestingly, 2 years later, we again came across a patient, and this time we could get genetics done. And this was a patient of autosomal recessive retinopathy who presented to us with macular RD in the right eye, and left eye had schisis-like picture, which was a clinical clue to the diagnosis of autosomal recessive BEST. Now, again, we reported this patient. What we learned from this scenario that after myopia and trauma, best vitelliform dystrophy is a common cause of macular hole associated retinal detachment. Moving on, coming to scenario three, we came across this girl, which was a 7-year-old at that time. She presented to us with decrease of vision for 4 months. The best corrected in the OD was 120, while in left eye, she was finger counting. What was astonishing was there was a massive retinoschisis, which was present in almost inferior half of the retina, while we could see the retinoschisis in the superior half as well. The OCT did confirm the retinoschisis in all over the retina, while in the left eye, this schisis progressed and had involved the macula as well. Now, we did get the full field ERG of this patient, which was negative, which did suggest a diagnosis of XLRS in this patient, but we were hesitant to make a diagnosis in a female child. So we went on to screen the patient, parents of the patient. And interestingly, the father of the patient showed a very typical picture of X-linked retinoschisis. We went back to the literature, and there are several hypotheses which explain why a X-linked recessive disease can occur in a female patient. So there are very few reported cases in the literature as well. So what we learned from this case patient was that X-linked disorders, especially XLRS, is definitely a possibility in females, and relatives must be examined to establish the diagnosis. Coming to scenario 4, we had a young male again who presented to us with nyctalopia since childhood and decrease of vision in both eyes for 1 year more in the right eye. In the right eye, this is the color photograph. We had extensive intra and subretinal hard exudates. There was a neovascularization of the disc on ultra-wide field FA, and not many details were visible. But the left eye posted a better picture where we had a typical picture of retinitis pigmentosa and infratemporal exudation along with bulb-like telangiectasia, and picture somewhat going into vasoproliferative tumor. So this patient we diagnosed with retinitis pigmentosa with Coats-like response, and we treated left eye aggressively. But in spite of 1 year of our treatment, 3 Avastins, 2 triamcinolone astronides in the vitreous cavity, 1 Ozurdex, and multiple sittings of laser photocoagulation, this patient kept worsening and went down to 3/60. It is at this stage we decided to go ahead with the surgery, did a PPV, released all the membranes, and did extensive laser photocoagulation. The patient did improve to 6/60 in the immediate post-operative period and was stable a year later with visual acuity of 6/18. So Coats-like RP has been described in up to 3 to 4% of the cases, but it is seldom so aggressive. But what we learned from this case is that PPV may be a viable option in cases that fail to respond to conventional treatment. So this is my last scenario. Again, I'll be presenting 2 cases here. Case 1 is of a 60-year-old male who presented to us with decrease of vision in the right eye. The patient was hypertensive. The best corrected in the right eye was 6/36, while in the left eye it was 6/9. Now on fundus examination, the picture was very typical of mactal type 2, where we could see the perifoveal pigment plaques in both the eyes. But what was peculiar was intraretinal hemorrhages in the infratemporal quadrant, which were away from the fovea. Autofluorescence did confirm the scattered RP changes, and we could see a hyperautofluorescent lesion as well. We did an OCT, which revealed changes typical of mactal type 2, as well as a fibrovascular PED, which was there infratemporal to the macula. And the left eye again confirmed a diagnosis of mactal type 2. Interestingly, the ICG of this patient revealed typical polyps, which were there in the infratemporal quadrant. So this patient was diagnosed to have mactal type 2 and PCV in the right eye, and left eye made diagnosis of pigment epitheliopathy, pachychoroid pigment epitheliopathy in view of the pigmentary changes. This patient went back to their parents' institute for further anti-VEGF therapy. A similar case was seen by us sometime later, 42-year-old male this time. Again, we had perifoveal pigment plaques and serous PEDs. And when we did imaging of this patient, we could see perifoveal leakage because of mactal and pooling in the PEDs. Left eye again had a typical picture of mactal with intraretinal crystals, right angle venules, and perifoveal glaying. And this patient again had some RP changes scattered here and there. So this patient, again, OCT showed a thickened subfoveal choroid with virtually obliterated choriocapillaris and serous PEDs. However, there was no evidence of CNV in this eye as well. So at the same time, Dr. Spade's group reported a paper where they described concurrent MACTEL and CSR, and they concluded that co-diagnosis of CSC and MACTEL type 2 should be considered in atypical presentations of both. And then we went ahead with our paper and we described our findings of pachychoroid spectrum of disorders in MACTEL type 2. In fact, from this, we got an idea and we analyzed the choroidal thickness in MACTEL eyes with the controls. And we did find that MACTEL type 2 patients actually had thicker choroid as compared to the controls. So what we learned from this, that MACTEL may be associated with thicker choroid and pachychoroid spectrum of disorders. So this is summary of my cases. Thank you very much for your patient listening.
Thank you, Dr. Vinod. And I'll invite Dr. Jay for his comments on MACTEL and pachychoroid. What is his take on that?
Thanks, Vinod. As usual, amazing cases. And yeah, I believe that now we are going to link, we are going to see more and more pachychoroid, or we are going to see more and more choroidal involvement in many of the diseases. And I have seen those papers, and some of the papers are clearly showing that there is a presence of thicker choroid. The biggest challenge is that where does this choroid plays a role in MACTEL, that is still unclear, because MACTEL, considering primarily in a inner retinal or retinal vessel disease, we are still uncertain whether it is the choroid is playing a role or not. However, having a concurrent CSCR with MACTEL, this is something which is becoming more and more common. I myself have seen a patient similar to that, where we saw the pigmentary changes and the cavitary changes as we see in PFT. But overall, fantastic collection.
Any comment from Dr. Anita?
I think those were excellent cases. My the best disease with macular holes. I think I might have reviewed one or two of those ones, and ARB. I agree. And the only one that the retinoschisis was the most interesting of all of them. The other ones you can easily explain, but you know, a 7-year-old girl with such extensive retinoschisis, I guess it can happen with lionization. Was genetic testing done in that child? Was there other family history, extended family history in previous generations about X-linked inheritance? That was my question for Vinod.
Sorry, I couldn't get that.
I said in the kid with the extensive X-linked, extensive retinoschisis, I don't know if I could call it X-linked yet. She was only 7 years old. You know, most of the X-linked diseases, if they occur in women, they occur much later in life because of the lionization. And unless you have severe lionization, that, I guess it's a little hard to think that can happen. But most X-linked diseases that manifest in women occur later in life, any of the other X-linked diseases. So I know you examined the dad, but was there any other extended family that you could ask about maternal? Because, you know, it should come theoretically maternally inherited for the X-linked diseases and goes to the guys, but because the father could give it to the daughter. But unless you did a genetic testing, it's hard to sort of think that that is X-linked foveal schisis.
Yeah, I agree fully to that. But the literature review we did, and there were a few similar cases where the father had features of X-linked retinoschisis, and all of them actually had very severe disease in the female.
Right, but did you do genetic testing?
No, that is the only flaw. In fact, I mentioned that we couldn't get the genetic testing of that patient. Yeah. And unfortunately, the patient was from a very far away place and we could not get other family members.
Was there more family history, like in the father's previous generations, like two, 3 generations? Unless you can really get that, it's hard to think that that is X-linked foveal schisis, especially the father having milder disease and the girl having more severe disease. That's kind of unusual too. Yeah. So I would still hold my judgment on that one.
Yeah, I think because even father did not that he was having any eye disease in the initial interactions. We just took the history and the patient, the father denied that he had any eye problem. But when we were stuck with the diagnosis, we actually examined him and we found that he had the features of X-linked retinoschisis. Unfortunately, the patient was from very far away, from a different state, and we could not get other family members to come in.
For the future, these cases, you have to do a segregation analysis, doing the mother's genetics and the father's genetics too, if you really want to tie it up. Maybe the mother's a carrier. You never know. It might have been sent through the female. That's why the kid has a severe disease. It's a little bit unusual for that to occur in a 7-year-old girl. So I would hold my judgment on that. It could be that the mother is a carrier. I mean, sometimes, these X-linked diseases carried by the women in the family and nobody else has it. And then the father maybe has the disease. And so maybe that's where the child has such severe disease. It's hard to just say it with just lionization. But that was a really good case. And I agree with the fact that the Mizuho phenomenon can be seen in other diseases. I personally have only seen one patient with Mizuho phenomenon. It was in a kid with young African-American male with retinitis pigmentosa, and cone rod, actually was cone rod. And otherwise, I've not seen one. And I don't have much experience about that.
Thank you so much. Thank you.
So terrific. I mean, a wonderful discussion. We could keep going on. It's now my pleasure to call on and invite Dr. Mudit Tyagi, Senior Consultant at LV Prasad, Hyderabad, who has a special interest in inflammatory retinal diseases and uveitis. So Mudit will play his talk of Sai system. So Sai, can you bring up Mudit's talk?
Just a moment.
And while we are about it, I think just to add to this, Dr. Anita said, female foveal schisis has been actually kind of talked about in literature too. But like you mentioned, I mean, all the genetics is...
That's the non-X-linked retinoschisis. Yes, I described it long ago. And now call it the sniffer. Yeah.
Sniffer,
Good evening. First of all, I would thank VRSI for allowing me to talk about some atypical presentations in uveitis. And before I proceed, a happy Independence Day to all of us. Now, uveitis is one entity where you can have multiple atypical presentations of the same disease. And it's that intriguing aspect where you need to put your thinking cap on most of the times. So I'll be presenting 3 cases. My first case is that of a 36-year-old male patient who came to our clinic with a sudden blurring in vision in the right eye since the last 3 days. At the time of presentation, his visual acuity was 21/60 in the right eye and 20/20 in the left eye. And what we saw was the presence of these choroiditis lesions over here. Along with that, there were granulomas superiorly as well as inferiorly. And you can see the subvascular pigmentation superiorly and along the inferior temporal aspect, and also some of the subvascular pigmentation and some patches in the periphery. Autofluorescence revealed the presence of this hypoautofluorescent area, along with some hyperautofluorescence inferiorly, and this choroidal lesion with hyperautofluorescent margins superiorly. An OCT through the macula revealed the presence of cystoid macular edema, and an OCT passing through the granuloma revealed the presence of a choroidal lesion over here with AC cells, and a picture which was classic of a choroidal granuloma. So based on the presentation of subvascular pigmentation, granuloma superiorly and inferiorly, we arrived at a clinical diagnosis of ocular tuberculosis. And when we investigated this patient, on expected lines, the MON2 came to be 30. The chest X-ray showed a few atelectatic lesions and few healed lesions and enlarged bronchopulmonary lymph nodes. The patient was non-reactive for HIV. So that kind of confirmed a diagnosis of ocular tuberculosis. But to our surprise, both VDRL as well as TPHA came positive for this patient. And we do test for syphilis serology for every single patient which is seen in our uveitis clinic. And so because VDRL and TPHA came positive, and on account of the fact that both of these tests have got a high specificity, and VDRL also, though having a low sensitivity, we have got TPHA which has got more than 90% sensitivity also for ocular syphilis. We decided to treat this in lines of a syphilitic uveitis. There have been reports of choroidal granulomas as a presenting sign of secondary syphilis, and therefore we went ahead and treated this patient on the same lines. So the patient was given crystalline penicillin for 14 days, And after 2 weeks of IV crystalline penicillin, what we found was that the granuloma superiorly as well as inferiorly had regressed. And an OCT shows a complete resolution of macular edema over here. And an OCT passing through the granuloma shows the complete resolution, and the entire granuloma seems to have disappeared. So within 14 days on crystalline penicillin G, we found that most of our lesions had gone. So what initially clinically presented or had a clinical appearance of a tuberculosis turned out to be a syphilitic granuloma. So this is what we see after 2 weeks of IV penicillin. Most of the lesions have regressed completely. And at 1 month, the patient visual acuity had improved to 20/30. So it's important to remember that when it comes to syphilis, the treponemal tests like TPHA stay positive regardless of treatment or disease activity. And like I had said earlier, they have got a high sensitivity and specificity for ocular syphilis as compared to VDRL, which is a non-treponemal test. Treatment of syphilis is on lines of what you do for ocular syphilis, is similar to that of what we do for neurosyphilis, with 18 to 24 million units of aqueous crystalline penicillin G given for 14 days. So the take-home message from this case is the fact that syphilis can be a great mimicker and it can present in any sort of way. And therefore, it is imperative for us to keep it as a differential for all uveitic entities. My case 2 and case 3 are kind of similar, but I will just deal with them. So this was a patient who presented with this triangular sort of a lesion in the periphery with this area of retinitis and this area of vasculitis over here in the periphery. And this patient was treated as an ARN and had been started on Valaciphyr before the patient presented to us. But the patient's retinitis lesions were not responding. And when we saw the patient, what we found was that apart from this area of retinitis, this patient also had this pigmentary scar over here. And the presence of a pigmentary scar and non-resolution of the retinitis on antivirals made us think that are we dealing with an ocular toxoplasmosis? And toxoplasmosis also has been known to present with lesions similar to acute retinal necrosis. So we treated the patient with Bactrim DS. And after 2 weeks, the lesions had started regressing. And at 1 month, most of the lesions had regressed. So this is the second case. And the third case is of a 29-year-old lady who presented with sudden loss of vision since 20 days, had these multiple areas of retinitis. This patient was seropositive incidentally and was initially thought of as having a CMV retinitis and was treated with 2 injections of ganciclovir. But even in spite of giving ganciclovir, these lesions had not regressed. And when we did an OCT, we found this entire area of retinitis with this vitreous adhesion superiorly at the edge of the retinitis lesion. And we have seen this sort of vitreous adhesion very commonly in our toxoplasmosis cases. So we started this patient on treatment for ocular toxoplasmosis, though we also did a vit biopsy and a vitrectomy and gave intravitreal clindamycin at the same time. PCR reports were negative for HSV as well as CMV, but were also negative for toxoplasma. But after starting that patient on treatment with clindamycin, the lesion started regressing. And so we continued the patient on Bactrim DS. And at 2 months, most of the lesions had completely regressed. And you can see this fibrosis and scarring nasally. And the macular lesion has completely regressed. And the patient's visual acuity had improved to 20/30, which is maintained even now at more than 1 year of follow-up. So the point to remember is that toxoplasmosis can present with a picture similar to ARN. And atypical presentations of toxoplasmosis can occur in seropositive patients. And my last case of the day is of a patient who presented with sudden decrease in vision in both eyes since 4 days. And what this case highlights is that all that you see in retina or all that you see in choroid may not always be uveitic. So this was a patient who presented with these bilateral kind of symmetrical lesions in the right eye as well as left eye and a history of decrease in vision since 4 days. A multimodal imaging helps in better delineating this lesion, and what you see is this lesion with central placoid lesion and these radiating margins superiorly which are emanating from the lesion, somewhat like a herpetic or a dendritic sort of an extension. So autofluorescence again revealed the presence of this placoid lesion over here with these dendritic extensions. An FFA was done which showed initial areas of hypo which then subsequently became hyper. And an IC also showed areas of this hypofluorescence in both the right eye as well as in the left eye. And this Subsequently, there was pooling of dye and staining over here. An OCT angiography through these lesions showed the areas of flow void areas in both the right eye and the left eye. OCT through the lesion showed these areas of damage or a photoreceptor damage over here, and this hyperintense lesions over here, or this hyperreflective lesion, which was suggestive of a photoreceptor damage which had occurred in both the eyes. So on repeated history taking, finally this patient revealed that the patient had been trying out lasers, and this was incidentally then finally a case of handheld laser induced maculopathy. So the important point to remember is that not all choroidal lesions may be uveitis, and when you see patient with a lesion like this, with a central placoid lesion but with these emanating dendritic margins, it is important to keep a differential of a laser induced maculopathy. So this is a case which was not actually uveitis but was initially thought of as uveitis, but a careful history taking and looking at the pattern made the diagnosis pretty simple. So central plaque-like lesions with vertical linear lesions emanating superiorly and inferiorly can be a clue to laser-induced maculopathy. And laser-induced maculopathy can lead to choroidal ischemia, which can be identified with the help of OCT angiography. With that, I would conclude all three of my cases. And once again, I would thank VRSI and wish everybody a happy Independence Day. Thank you.
Thank you so much, Mudit. I think they were really interesting cases, and it makes you thinking not to be all the time diagnosing uveitis. I would request Professor Gupta for his comments, please.
I think you're muted, sir.
So you are muted.
You're muted, sir.
Sir, please unmute.
I think the last case was very impressive. You know, when we saw a similar case some years ago, it really foxed us. And unless you are aware of this entity, the laser pointer injuries, you know, you're likely to be mistaken all the time. So you have to keep that in mind, particularly in children. You know, they keep playing around into, you know, these laser pointers, very powerful. They're available on Amazon and other places, very cheap. And one has to be aware of these. For your cases, the syphilis, I think we have always tested all our patients, you know, for syphilis, because it can present any which way. So I would always investigate them for that, rule it out before jumping onto the TB gun, you know, because TB can wait, but syphilis, perhaps we can very effectively treat it. And whenever we see, you know, atypical presentation, I have a very low threshold for doing a diagnostic surgery. And you have to keep in mind, some of these patients are undiagnosed HIV patients. You may be the first person to see them, and there may be mixed infections. So, you know, when you talked of ganciclovir and not effective acute retinal necrosis, the patient might have had both toxoplasma and varicella zoster or HSV. So the mixed infections are in fact very well known in HIV patients. So we have to keep all our options open in these patients. But excellent documentation, congratulations. I think we saw excellent documentation from Vinod Kumar. I think he comes out with absolutely fantastic cases every time I hear him. So great meeting. Thank you, Anand.
Dr. Anita, any comment from you?
The laser pointer thing is, I mean, that if you've seen that fluorescein and you've seen that OCT, you know that's what's laser pointer injury. And the curvilinear things that T call dendrites, dendritic looking ones are absolutely typical. And you want to look at the pupil margin to see sometimes, you know, there are little burns at the edges of the pupil. And if you see the hyperfluorescence on FA, it's nothing else but laser pointer. And sometimes it's unilateral and sometimes it's bilateral. There was a big discussion going on at Duke, and I told them this is laser pointer because I actually missed it the first FA. I just like, because they only had one fovea lesion and didn't have anything else. And I said, this is atypical for MP to have one eye and the other eye was fine. It was a girl. Most of the time it's boys. And they're all in the young age group. And the most important thing is first to recognize. Second is they all have some sort of a compulsive behavior. So they need absolutely, first of all, you got to remove the laser pointer from them, and you got to make sure that their friends and their siblings don't have laser pointers too. Otherwise, they have this impulsive thing to go on doing it, and they'll damage themselves. It's a psychiatric condition, so they may need referral to a psychiatrist. So you have to be very, very careful. You have to take the patients into confidence. First, you got to take the kid into confidence in a separate room and get the history from the kid if he has a laser pointer, and then you have to tell the parents separately. So you got to be very. That's when I just had a kid. Just a few weeks ago with this, and came much later on, and the mother was not his mother, and was a lot of family dynamics in the States that was very difficult to kind of go around, but I had to kind of take them, both of them separately into confidence and sort of explain to them, but we'll see what happens to the kid. And the Duke kid was a girl. It's unusual for a girl, but can happen. It's unilateral. The Duke guys were convinced it was a worm, and they went and said, oh, we did laser and the worm's gone. And then the lesions all became inactive because she was getting recurrent crops of lesions. And then I told them, I said, this is laser pointer, you have to watch out and things like that. And then as soon as they diagnosed the worm, the kid said, oh, yes, I'm cured, I'm fine. And she came back with the second eye involvement a few days later. And then the minute they asked her, do you have a laser pointer at that time, the kid ran from the clinic and ran away saying that I already know that I have a worm in my eye and it's not a laser. So they deny. So you have to be very, very, I mean, you have to really watch out for these kids and somehow get the whole social people that are involved with the kids' care to kind of be involved so that they really take the laser away from the child. And sometimes, their friends have it and their siblings have it. My kid said his brother had it, and he was a half brother, I think it was foster care and all sorts of things. So to be very, very careful of that. And those are, extra pointers that I would say, but otherwise those cases are extremely descriptive and classic and typical of laser injury.
I just want to make a...
Yeah, sure, go ahead.
Yeah. Mudit has already discussed that case with me, and I think the whole attention in Mudit's presentation is on laser-induced maculopathy case. But Mudit, if we really think beyond and see that tomorrow, if I see a patient like that, your OCTs are showing that inflammation is still active, because you could see that the thinning has not yet occurred, scarring has not yet occurred. You are still seeing the hyperreflectivity, linear signals are still present. So my question is that tomorrow, if I really see this patient, what am I going to offer him? Am I going to say that this is a laser-induced maculopathy, let's have one more conference and present that? Or are we going to offer them some treatment? So should we be considering giving them some form of intravitreal steroids to reduce the inflammation, which might reduce the scarring at the photoreceptor layer? Or should we be offering them some sort of treatment if somebody else can come up with? Because I was just thinking that there is an active inflammation, and we rarely see, like Anita said, we rarely see these cases at an acute stage, but you were lucky to see that. Do you think that we should be offering them some form of steroid to reduce the inflammation?
So we did actually.
You are a specialist. You are very used to giving steroids.
So we did end up giving this patient steroids, and the patient's visual acuity improved finally to 20/50. There is still some, at the end of 2 months now, what we saw was some RP atrophy over there. But the point is, I still do not know whether my steroids helped or was it just a natural history in which the patient improved by itself. But then at that point of time, we had no other option. So we did end up giving steroids. Whether they have helped or whether it's just the way the disease has healed by itself is something which I honestly don't have an answer to.
I think the early lesions get better with visual improvement, but if they keep on having recurrent injuries, then it'll get bad. So many of them get better. It's sort of like a little bit like Popper-induced maculopathy, but where the lesions are in the outer nuclear layer, and they get better. So if you catch them very early, it's important. And I think with or without steroids, I think they get better. And unless they keep...
I think Jay raised a very important point. If you catch them in the acute phase with a lot of inflammation, a lot of edema, I've just treated a child about a year and a half back where there was a toy burst. There's a toy burst, and it was a bilateral, very florid injury. It was a burn through, and we rushed in steroids, parenteral steroids, as much as we could, and it settled down over maybe a couple of weeks. And that could never have happened if we had left the patient to themselves. So I think that is an important point, even for the surgeons. Foveal injury, sometimes that filter doesn't come in, even for surgeons. I think the first thing is to go in for steroids. I think
maybe
that's
if
point well
I
taken.
see, I might offer them intravitreal dexamethasone, which works very quickly, dissolves very quickly, does not lead to any side effects. You might actually end up healing those lesions much faster and prevent the collateral scarring.
Actually, in one case, we did that for one eye. We did that for one eye.
Very nice case. Thank you.
Thank you.
So I was in particular interested, Mudit, in your first case, and I wanted to specifically ask Professor Gupta. The first case where you showed, the very typical granulomas with the perivascular pigmentation, and even the Mantoux was extremely high as 30 in your patient. So if clinically anybody was to see a patient like this, I think 90% cases you will diagnose it as ocular tuberculosis, what you also initially thought of. And the entire diagnosis apparently changed when you got a VDRL and TPHA positive. So I wanted to ask Professor Gupta, I mean, if you have a case like this, very often I know patients don't do a syphilitic testing, though I know it is mandatory these days. So, sir, what exactly would you be recommending? I mean, do you just stick to an ocular?
I look at it, I look at the hierarchy of evidence. When I compare TPHA or VDR positivity versus the tuberculosis skin test positivity, in hierarchy of evidence, I think TPHA and VDRL goes much higher. Okay, so I would like to treat it on the syphilis lines. Okay, for instance, in a patient with acute anterior uveitis and he's HLA-B27 positive and he has a Montus also positive, we know that HLA-B27 is a much stronger association with acute anterior uveitis, so I'll ignore the TB test. Okay, but in the same patient, if I had a TPHA positive, okay, I will think again, because TPHA is not ordinarily false positive. VDRL can be false positive, but not TPHA. So if it is positive, I'll think of, considering syphilis as a possible cause of that acute anterior uveitis. So I like to weigh the balance and in what order of evidence we are going to treat. So I decide on that basis.
Thank you, sir. And over to you, Anand.
Thank you very much. I think we've had an absolutely exhilarating session. I mean, it's just left me to thank, first of all, Professor Amod Gupta for taking time out and, as usual, enlightening us with a fantastic talk. I'd like to thank Dr. Anita Agarwal, who's been such a great support to all VRSI activities, and her knowledge is encyclopedic. She brings with herself the experience with none other than Don Gass, and of course, coming from PGI Chandigarh also. And thank you so much, Jay, for always sticking with us and giving in your insights. Dr. Mahesh Anmugam, Dr. Muna Bende, Dr. Shukla, Dr. Mudit, Dr. Vinod, fantastic talks, wonderful talks. It's been absolute eye-opener. It's been a perfect day for, as a right kind of ending for an Independence Day session. Thank you so much, and hope to join with you again in future VRSI webinars. Thank you very much. And I'd like to thank Manisha too. For
thank you, Anand. Thank you, everyone.
Thank you very much.
Thank you. Thank you.
Bye. Good night.
Thank you, Anand.
Thanks. Good to see everybody. Thank you.
Good night.